Screen share. All right,
Am I good?
it's all you. You're good.
Okay. Oh my gosh, more people. Okay, so I'm Haley, and my topic is the comparison of using antibacterial foam and soap and water to decrease bacterial count on the hands of hospital nurses. So that was my PICO question. In hospital nurses, does antibacterial foam decrease bacteria count on hands as much as hand washing with soap and water? A little background, so hand hygiene is obviously the primary way of preventing the spread of infection in both the hospital setting and in just the general public. The use of antibacterial foam is less time consuming than washing your hands in soap and water, but both regimens are effective. I'm doing my practicum in the ER, so I have noticed that whenever I get out of a patient's room, I do hand sanitizer rather than going to the bathroom to wash my hands, just because you're honest, like you got to be very fast and you just do hand sanitizer before you go to the next patient. And I find that very less time consuming. So my first article that I found is the effects of hand disinfection with alcohol hand rub, ozonized water, or soap and water. So this article compared the effectiveness of using both an alcohol hand rub and soap and water in the removal of E. coli. The sample size that this study had was 35 individuals using the alcohol hand rub and then 55 individuals using just soap and water. The method used was a non-pathogenic strain of E. coli that was used to contaminate the hands of the participants, which followed with the disinfectant procedures of using either the alcohol hand rub or soap and water. Based on the final results, the most effective method used was the use of soap and water to remove the E. coli from the participants' hands. My next article was using alcohol for hand antisepsis. And with this particular study, only included 29 nurses from 3 different areas of the hospital that participated in a trial to compare the effectiveness of using alcohol hand rub and soap and water. The nurses stated that the important advantage of alcohol hand rub is that it only took 15 seconds to use in between patient care, whereas it approximately took 60 seconds to use both soap and water and then dry their hands and return to patient care. So with this trial, the nurses that visibly had dirty or contaminated hands used both the alcohol hand rub and soap and water and came to the conclusion that using soap and water was the most effective way in removing bacteria from the hands, but the alcohol hand rub was less time consuming. My next article that I found was hand hygiene with soap and water is superior to alcohol hand rub and antiseptic wipes for removal of Clostridium difficile, also known as C. diff. So the purpose of this trial was to evaluate the use of alcohol hand rub and soap and water and the efficacy in removing C. diff. The sample size included 10 random volunteers with hands experimentally contaminated with C. diff. The interventions used were evaluated for a mean reduction in colony-forming units under 2 contamination protocols, which was either the whole hand or just the palmar surface of the hand. Both protocols showed a mean reduction using soap and water. So in conclusion, hand washing with soap and water showed the greatest efficacy in removing C. diff and is recommended over the use of alcohol hand rubs when in contact with C. diff is expected or likely. My fourth article was the comparative efficacy of hand disinfection potential of hand sanitizer and liquid soap among dental students. So the purpose of this study was to compare the efficacy of using hand sanitizer and soap and water in the reduction of microbial colonies on hands. The sample size included 90 individuals that attended a dental college, with half using hand sanitizer method and the other half using the soap and water method. The participants were instructed to contaminate their hands for a pre-swab and followed with the two regimens, the soap and water and hand sanitizers, for a post-swab method. The results shown that the reduction in microbial colonies was highest when using hand sanitizer, but it also showed a reduction in using soap and water, but not as much as hand sanitizer reduced it. My fifth article that I found was the knowledge, attitude, and self-reported performance and challenges of hand hygiene using alcohol-based hand sanitizers among healthcare workers during COVID-19 pandemic at a tertiary hospital. So the focus of this particular study focused on the practice of using hand sanitizer among healthcare workers during the COVID-19 pandemic in a medical center located in Ethiopia. I could not find another article that based it on COVID or in a hospital setting, so this one would have to do. The sample size included 96 individuals that were working the front lines during COVID-19. Most healthcare workers performed hand hygiene by using hand sanitizer to prevent and monitor the transmission of the COVID-19 virus. So with this particular study, in conclusion, recommended the use of hand sanitizer over the use of soap and water, just because alcohol hand rub was less time consuming, and with the number of COVID-19 patients in the hospital, you just had to go to patient to patient to patient. But it also showed that alcohol hand rub was most effective in decreasing bacteria count. So the synthesis of my literature, so 3 of my studies indicated that using soap and water was most effective in decreasing bacteria count. And in 2 of my studies, it indicated that using antibacterial foam was more effective in decreasing bacteria count. And the only common factor in all of my studies is that the only way to decrease bacteria count is just performing hand hygiene and being compliant with the use of hand hygiene. So in conclusion, it is proven that hand hygiene using soap and water is more effective in decreasing bacteria count than using antibacterial foam. Therefore, the research studies found that hopefully improve the nursing profession by showing that the use of antibacterial foam is not as effective with decreasing bacteria count as it would be to use soap and water. So just wash your hands. And there's my references. Any questions? Okay. Okay.
Did they say anything to the effect of how many times you should use sanitizer and then go to soap and water?
It did not say.
So no, you really can pick up that sanitizer again.
Yeah,
Soap and water. Okay.
nothing was said about that in any of my articles that I found.
So I use that gel stuff.
Yeah.
And I know that your research was on the phone.
Yeah.
Do you know about the gel?
I do not know about the
Okay,
gel.
that's an unfair question because that was not your research.
I do not know about the gel. I do know just the foam part was
Yeah.
less
That was
effective.
what your study was. So I was
Yes.
just asking.
Yes,
That's a side note question.
Yes, ma'am.
Your old EMT is coming back out.
I'm sweating. Any more questions?
You did a great job.
Thank you.
Stop sharing, share screen. No, share screen. Now do this one that has the, does that make sense?
Yep.
So now they're seeing this one.
So this,
They're
okay.
seeing.
Are they, they're not seeing this though, are they?
Nope, they don't.
Okay.
They're seeing what's up there.
All right.
Thank you, sorry.
No, you're fine. Ben.
Just the arrow keys?
Yep, and then just adjust this so that you're in there.
Okay.
And would you like a time card on this?
Time card.
Yeah, like if you get like 2 minutes or 1 minute, how many minutes?
Is it okay if our friend knows that I can minute, but I cut it off?
No, we'll just signal you, but you know, I just, do you want to?
I'm okay.
Because Whitney is back there and she has the cards.
Okay,
Yeah,
okay,
so
good.
she's letting them know.
All right, sure.
All right. Good.
Hey everyone, good afternoon. My name is Benjamin Coakley, and today I'll be presenting over the use of the Stellate ganglion nerve block technique in the reversal of ventricular tachycardia electrical storm. So my research question is the Stellate ganglion nerve block an advantageous alternative to the treatment of patients with this ventricular tachycardia electrical storm? With our population being acute care patients that are experiencing this condition, the intervention being the Stellate ganglion nerve block, and the comparison being the same population before and after treatment with the goal of improving outcomes for patients with this condition. So a little bit of background information to explain what the heck I'm talking about. Ventricular tachycardia or ventricular arrhythmia electrical storm. I'm just going to say VAES from here on out instead of that mouthful. It's an electrical disorder which causes the heart to have uncoordinated and rapid contraction of that cardiac muscle, which can lead to incomplete filling of that blood flow, and that's poor. So the blood doesn't get pumped properly to your vital organs, and that can lead to cardiac arrest and death. What makes storm different from an arrhythmic episode is when you have multiple concurrent episodes that go back to back to back. And every time this happens, the shock that your body goes through, if you're defibrillated, the shock that gives to your heart, that's going to increase that endogenous catecholamine release. So your adrenaline is going to be flowing. That cardiac tissue gets more and more agitated and more likely to have another episode. So that's a positive feedback loop where every time this happens, it makes it more likely to happen again. So we have to treat this aggressively, and it's not something that we can wait and see with because it's just going to keep happening. So what is the current treatment approach that we're comparing to? Well, this is that classic thing you see on TV where they break out the old school defib paddles and shock the patient. But we don't always shock. A friend of mine likes to say if they have a pulse, we'll try and treat you with medication. If you don't have a pulse, Georgia Power. But we have to be aggressive with this. So antiarrhythmic drugs, defibrillation, as I mentioned, sedation to reduce that agitation, intubation if we have to protect that airway, hemodynamic support, cardiac specific beta blockers like esmolol to reduce that cardiac excitability. But a lot of these patients will ultimately require a cardiac ablation, which is a procedure that's done in a cath lab, a sort of operating theater where a catheter is peripherally inserted, brought to the heart chambers and tries to destroy that tissue that's conducting incorrectly to try and reverse this problem for good. So what the heck is a Stellate ganglion nerve block, which I'm just going to call SGB from here on out and save my mouth a little bit. But the Stellate ganglion is part of the sympathetic nerve chain. That's your brain telling your heart, get up and go. And the ganglion itself is located between the C6 and C7 vertebrae. And the nerve block is an injection of a nerve block agent into the ganglion itself to interrupt that conduction and interrupt that stimulation to the heart. Historically, this has been done more often in an outpatient pain control or pain specialist scenario. And more recently, it's been considered as something that could be used to stop this autonomic stimulation of the heart during VTAC. So, however, there hasn't been a large body of research on it yet, and it's still relatively recent. So that's why it's something that I wanted to talk about. It's not widely incorporated. Here's just an illustration of that conduction along the axon of a neuron, and lidocaine, a sodium channel blocker, can interrupt that conduction. So that's kind of what we're talking about here. To review my literature, my first article is a systematic review published by the Health and Human Services Department. Over 3,000 publications were reviewed for patients that had VAES, that was drug refractory or drug resistant, that were treated with the SGB. They found 38 patients that met this criteria. And what they found was that the average number of episodes, arrhythmic episodes that patients went through on a daily basis went from 12.4 a day down to 1.04 after the nerve block. And they found that the average number of defibrillations a patient needed a day went from 10 to 0.05. So here's a quick table kind of illustrating this dramatic decrease in both the arrhythmic episodes per day and the number of defibrillator shocks required a day before and after the SGB procedure. My second article was published in the American Heart Association Journal. It's a single center review of 30 patients on a 5-year period who also had drug refractory VAES who received the SGB treatment. And what they found was that 60% of patients had their were free of VA after 24 hours, and that there was a 92% reduction in ventricular arrhythmic episodes after 72 hours. Something I thought was important about this study too is that they found no procedural related complications from this procedure. So that's a safety point to compare to our other treatments. They also included a table that's similar to the previous one, showing the dramatic decrease in the number of arrhythmic episodes per day and the number of defibrillator shocks required per day. My third article was published in the Journal of Anesthesia. The authors were doing 27 different SGB injections with 4 different approaches to try and compare from their experience what was the safest and easiest way to do this procedure. And they found that all their injections were successful and effective within 5 minutes, and that the lateral approach with an ultrasound machine was the safest and easiest. And importantly, that there were no major side effects. So I just wanted to include this to kind of show that this is something that can be safely done at the bedside. My fourth article was published in the European Heart Journal. It was a meta-analysis and systematic review of 71 patients that received a cardiac ablation, that procedure we talked about earlier in the cath lab. This is just to compare to the nerve block that I'm presenting today. So what they found was that 72% of patients were successfully had their arrhythmic episodes terminated, but 9% were failed procedures. And for every failed procedure, the likelihood that a patient would expire was 4 times higher. They also found that 3 patients experienced procedure-related mortality because of the procedure, and that 6% had a recurrence of ventricular arrhythmia. So I just wanted to bring this up to show that, that while this is effective, it's not necessarily the easiest or safest procedure to go through. My last article is a case study published in the AHA detailing a 7-month-old female patient who was born with congenital heart defects that was causing electrical storm. So after birth, she required resuscitations, multiple hospitalizations. She had a cardiac ablation and had an internal defibrillator implanted. However, at 7 months old, she had recurrent electrical storm that was not being controlled with medications or the defibrillator. And she was on a heart transplant list. She was a candidate to get a heart transplant. Because their circumstances were so dire, they decided to try and do this nerve block, even though there was not a lot of research, especially in infants at the time. And what they found was that after 20 minutes, she was able to maintain a normal sinus rhythm up to 24 hours. So they were able to repeat this procedure on a daily basis for 35 days until she could get her heart transplant. So I just wanted to include this to kind of show where it can fit in our current treatment plans. And you can see her heart before and after the shock on the A slide, and B, the sustained normal sinus rhythm here. So to kind of summarize and synthesize my literature, we had some systematic reviews and meta-analysis, some case series studies, and that case study in the last article. I think the strengths of this research, we can demonstrate that it can effectively reduce ventricular arrhythmias in the majority of patients and kind of show where it fits in our treatment. And show that it's a pretty safe procedure with no major side effects. There is definitely some weaknesses though. These are all retrospective studies with small sample sizes. And there are a lot of confounding factors. We might be able to treat your electrical storm now, but maybe not your heart failure. You know, these patients have so much going on that it can be hard to determine how much good we're doing if they're so sick. And with patients that are this sick too, we're making life or death decisions. So they're not running experiments on these people, right? Like, not going to choose who does and doesn't get treatment to try to get experimental data, right? So that's going to be a confounding factor. To answer my research question, is this an advantageous alternative? I would say it's an advantageous addition to our current treatment protocols. Main advantage is that it successfully terminates ventricular arrhythmias in the majority of patients. And it has some other advantages too. It can be done at the bedside during an emergency. It's inexpensive. Not every facility is going to have a cath lab, but ultrasound machines and lidocaine are everywhere. It's relatively simple and safe. At the end of the day, this is just an injection that with a practiced and trained hand can be done. And it's highly specific and targeted with little systemic effects. And it can last up to 24 hours, which buys a lot of time for patients who may not have a lot of time. There are definitely some drawbacks too. It's not necessarily more effective than cardiac ablation for long-term treatment of electrical storm. And we do need a larger body of evidence to really incorporate this. So for the relevance and significance to nursing, I think that we got to be careful. We got to be prepared to treat these patients in our hospitals and know what their clinical course is and be prepared for emergencies. And also, as some of us become nursing managers, educators, and researchers, we need to always be advocating for the addition of, or the incorporation of new practice and new research into our practices. For me personally, I'm interested and passionate about this. There was a patient in the emergency department that I work at who did have electrical storm. She had an internal defibrillator that wasn't firing correctly or consistently. And during her first episode with us, she didn't have a pulse. So as we're starting CPR on her, her pacemaker finally fires. Her eyes like open wide. She grabs my arm. She's like, "Stop that!" And I'm like, fair enough, fair enough. But we ultimately did have to shock her 5 times in the last 3 hours of my shift. And besides shocking being painful, all that electricity to the heart is not necessarily healthy in the long term too. So when I learned about this SGB nerve block, I immediately thought about her and was wondering like if this was something that was more widely incorporated or something that we had more research on, could she have been a candidate for this and would this have improved her outcome? So that's kind of why I'm interested in this and why I chose this topic. That is all I got for you. No, this can certainly be done in the emergency department. All you need is an ultrasound machine and a training room. Sure. Perhaps, yeah. I think that's fair. Yes, ma'am.
So we're kind of going away from lidocaine, basically on for pulse. So
Okay.
did they try anything other than lidocaine? Or
Yes, ma'am. They tried buvidicane, I think, was one that was actually used more than lidocaine. I just used lidocaine as an example that people will be more familiar with. Yes, ma'am.
I think you sounded like a cardiologist.
Definitely not yet. Or ever. Thank you.
Reed, are you ready?
All right. Hey everybody, I'm Reed, and my presentation is over Do Vapes Help Smokers Quit Cigarettes? Right, so everybody knows that cigarettes contain nicotine, which is a physically addictive chemical. So anybody who's trying to stop nicotine or cigarettes are going to have withdrawal symptoms, so physical withdrawal symptoms like cravings, emotional irritation, restlessness, sleeping and concentration issues, and anxiety and depression. So most of the time, whenever you're trying to stop cigarettes, you're going to use some form of a nicotine replacement. So nicotine patches, lozenges, or gum. So smoking tobacco is the leading cause of lung cancer in the United States. And the World Health Organization states that over 8 million people die prematurely every year from smoking-related diseases. And then everybody, I think, knows that there's been a recent surge in popularity of things like Juuls or other electronic nicotine delivery systems. So that's the ends that you'll see here. Basically just vapes that supply nicotine. And these are often marketed as an alternative to smoking. So that brings us to my PICO, which is with tobacco smokers are those that make a switch to vaping more likely to cease tobacco smoking when compared to those who do not make a switch to vapes. So population is tobacco smokers, we're looking at them making a switch to vaping and just seeing if they're more likely to stop smoking. So with a relevance to nursing, you may have somebody come to you and ask if they could use vapes as an alternative to therapy, like instead of using gum or nicotine patches. They may still want that hand-to-mouth mechanical thing that they're used to with cigarettes, and they could get that with vapes. So I think it's good to know just whether or not these would be considerable. So these are my articles, 4 of them. So these are all my high-strength articles. I'm not going to go through the names of every one of them, but I have 2 level 1s. They're both systematic reviews and meta-analysis of randomized control trials. And then I have 2 level 3s. And I also have 3 more lower strength articles, a level 4, a level 5, and a level 6. So all of my high strength articles compiled. The first 2, those 2 level 1s, like I said, they're systematic reviews and meta-analysis. So basically just compilations of randomized control trials, and they're looking at the overall findings that they found throughout all of them. And so they found that nicotine delivery systems, electronic ones, so vapes, are an effective method of replacement therapy. And they suggestively indicated that they could be more effective than traditional replacement therapy when you're looking at long-term effects. And also noted that there's no severe effects in either nicotine gum, nicotine patches, so traditional, or vapes. And then the next one is a level 3. It's a secondary analysis of cross-sectional baseline data, which predicted that vaping reinforcement would positively predict the likelihood of somebody to stop smoking. So that is just reviewing data from other research and repurposing it to look at the effectiveness for this. And so they found that the attitude or goal of the user when using vapes is a better indicator for the effectiveness of this. So basically, if somebody is going to be using a vape as an extension of their smoking habits, it's going to be a lot less effective than somebody who's like, I'm using these specifically to stop cigarettes. And then the last one is a cross-sectional survey-based comparison. So just a comparison between vaping and non-vaping former smokers, and just a survey asking them questions. So they found that the vapors were more likely to report the following when compared to the others. Having vaped within 5 minutes of waking up, still feeling like they're very addicted to nicotine, but feeling extremely confident in their ability to stay off cigarettes themselves. So while they felt like they were more addicted to nicotine because they're still using vapes as a replacement therapy, they felt more confident in staying off cigarettes. Okay, so low strength articles. The first one, that level 4, is a longitudinal study. So they're just looking at individuals over time and changes with them. So again, they wanted to see if vapes achieve abstinence compared to other therapies. And so they found that 1/3 of the total sample of vapors were chemically confirmed to be abstinent 7 months after quitting cigarettes. And so they concluded that the vapes may be a viable option. And then the next one is a level 5. It's a non-randomized control trial. So it's another meta-analysis conglomeration of all these 64 randomly chosen studies they're looking at. And they found that vapes warrant consideration as a prescription rather than a consumer product. So right now they're not FDA approved. We don't know exactly what goes into them. There's all kinds of variables. So they think that it would need to be a controlled product, obviously, if you're going to be recommending it in a clinical setting. And then the last one is a descriptive self-reported study. So just exactly what it says, a self-reported study. And they were just surveying people who were coming in and making their first purchase at a vape shop. And they found it possible with substitution and professional advice to achieve high and stable success rates in cigarette abstinence. So all of those articles' limitations sort of summarized. The high strength articles found minimal evidence, so they had a lot better, they weren't as limited as far as like the methodology and things like that, but they found minimal evidence. And then the low strength articles found much more evidence, but they had a lot more limitations. So things like small sample size, the self-reporting, the surveys, there was unmeasured variables, short follow-up periods, so they're not looking at long-term things, and then incomplete and missing data. due to dropouts. So a synthesis of all of that. So basically, like some of these others have already mentioned, more evidence is going to be required and analysis. So from high strength, these level 1 through 3 types of research. And there also seems to be some evidence, it seemed like throughout all of these, that they're at least as close to effective as replacement therapy, but not necessarily that they're more effective. So in conclusion, I personally would not feel comfortable recommending this right now. Like I said, we don't know what goes into these. They're not FDA approved. We don't know the long-term effects. They've only really been popular since I say really popular since 2017, even though they've been out a little bit longer than that. And I spoke to a respiratory therapist who was mentioning she's seeing people come into emergency departments who have been using just probably uncontrollable amounts of vapes, but they're seeing EVALI, which is electronic vaping associated lung injury already. So I think, like they said, it would need to be controlled research prescriptions where you really know what's going into them before you can really start to make a conclusion on that. That's my presentation. Questions?
Okay, so I know you mentioned it was effective in reducing the need for nicotine, but do you see anything from the articles related to the inhalation damage?
Okay, so they weren't really looking at any of that. So that's a big concern, the combustion of everything. And like, I just think, like it said, it would have to be, you'd have to have that prescribed and controlled thing and then do studies and looking at those really in depth. Because right now, all it was really just saying, hey, they don't need to use cigarettes as much because they're using a vape. No, not. Yeah. And yeah. Yeah, exactly. So still, you'd have to really have some therapy to sort of mitigate that. Yes, ma'am. Anybody?
Okay. Thank you. All right, Jessica.
At this time, if you have not scanned the sign out to QR
Come over here so I can make sure the camera's on. So just make sure. I just slide over this right here.
Hello. I'm extremely nervous, so forgive me in advance. My name is Jessica Pauling. My presentation is on the psychosocial needs of mothers and whether focusing on that would have a positive effect on preterm infants in the NICU and their care. So the World Health Organization cites premature birth as the #1 leading cause to infant mortality and morbidity in the world. This is not a United States problem, it's a worldwide issue. Any birth before 37 weeks gestation is considered premature. The earlier the birth, the higher the risk of disability. There are psychiatric symptoms and mood disorders that are attached to normal birth with hormonal changes and just the experience of something new. But traumatic reproductive events such as admission to a NICU can exacerbate the onset of already existing psychiatric symptoms. Toxic maternal stress consistently linked by researchers to a lack of physical and emotional closeness in the NICU setting. These mothers can experience contradictory emotional reactions to giving birth, such as feelings of failure, devastating loss, inadequacy, and sadness. There's been a recent spike of interest in a mother's postpartum mood and a child's development. Little emphasis has been placed on the opposite. So my first article was a study done in Turkey. It was conducted in 2 separate NICUs that were affiliated with the 2 largest medical hospitals in the country. Data was gathered from 106 mothers that had premature infants that were hospitalized. The parental stressor scale was used, which is a 34-item scale. Parents can rate their stressors from 1 to 5 on a scale of 1 to 5. It was determined that mechanical ventilation and parenteral nutrition, infants that were attached to machines, that their stressors were particularly high. The nursing support levels of mothers with middle to low income were actually rated higher than those of high income, which I thought was kind of interesting. And the predictive power of respiratory and nutritional status was obviously established in the study. My second article was, it was a collaboration between, it was done in the United States, it was a collaboration between the Johns Hopkins Bloomberg School of Public Health in Baltimore, Maryland, and the Feinberg Study of Medicine in Chicago, Illinois. This study was done, it was a controlled design with telephone interviews being given for the parents of 10 NICU infants and their experiences post-discharge. It identified the parenting challenges that they experienced at home after being discharged, the support they received from family, friends, and health professionals that addressed their particular needs. The defining characteristics were, life and death struggle. These were the words of the participants in particular. Things got a bit dire was one theme. The trauma of the unknown, life and death struggles, being separated, and feeling like they slipped through the cracks were things that were commonly evaluated by researchers. This study was done in Sydney, Australia. It was to explore the experiences of mothers with extremely early premature babies that were admitted to the NICU. Many mothers experience something called acute stress disorder, which is different than post-traumatic stress, whereas it has a duration of 3 days to 1 month. That's the onset of the disorder. 10 mothers of extremely premature infants who had been home for less than 6 months were evaluated. Questions focused on events leading up to their birth, their experiences in the NICU, parenting education they received prior to being discharged, and the challenges they experienced at home. Stress levels were analyzed among these mothers using the parental stressor scale. The sample size was small. The research team concluded that it would be necessary to have a psychological counselor who interviewed all of the mothers independently. Maternal stress was identified as the most significant stressor. Holistic care to the family was the best guarantee of a good outcome for these parents. This study was done in Korea. It has been established in Korea that the maternal involvement in care is the #1 best way to guarantee a good income. However, there hasn't been a whole lot of research done on what needs in particular nurses should focus on. Excuse me. 4 themes emerged. The greatest unmet need was relationship-based support. That was followed by information and educational support, system-level challenges. It was concluded based on their data that the mothers desired a more family-friendly oriented NICU. Clinical transparency was also an issue, as well as anti-infection management and better staffing levels. Nurses that consistently supported the families by being attentive were needed, and empathetic concern and warm words. So the literature all concluded that, the psychosocial and emotional needs of the mothers will improve the mental health outcomes. However, as I did research, I realized that it's a field that hasn't been studied a whole lot. So there's the need is to dive into the studies and identify specific areas and the differences in how they can be approached. The mothers that are high risk of developing PTSD, lack emotional and physical support, recent significant stressors, low self-esteem, and high anxiety levels were issues. But with systemic and consistent research, particularly with this cohort of new mothers, we can identify early interventions and reduce the risk. It needs to be organized, establishing the specific cognitive and social structures that need to be researched further. These were the common themes that I saw in all the studies. They highlight the need for nurses to focus more on psychosocial needs, meaning psycho and social. The studies all concluded that supporting the mental health of mothers of preterm babies not only will improve maternal well-being, but there will be a positive impact on the infant who has a caregiver who's now emotionally available and responsive to what the infant needs. The research shows that these mothers of premature infants, are at a particularly high risk of developing PTSD and or other illness due to a continuing lack of emotional and physical support, recent significant stressors, and traumatic reproductive events. The impact on healthcare is that, like I said, this is a worldwide issue. 23 million babies are born premature every year, and it's still not recognized as a significant public health priority. International health committees, donor organizations, and governments lack the evidence on a global, regional, and local scale, which can be due to misperceptions that the cause of newborn deaths and the limited public awareness lead to inattention to these particular problems. Resources are now being used to explore the psychosocial, familial, and social impact of spontaneous premature birth, especially in subsequent pregnancies. Evaluating the relationship between premature birth and inequalities of outcome experienced by Black, African, and Black Caribbean women are particularly important. Exploring the relationship between pregnancy events, biomarkers, and medium long-term outcomes in preterm neonates using public health data and interviews is also recommended. Research in maternal NICU interventions needs to be done on a larger scale, as well as randomized controlled trials. Establishing the specific cognitive and social structure barriers need to be met, and the data will help improve professional education for midwives, nurses, and other healthcare professionals, requiring increased awareness of the psychosocial needs of mothers. I'm really nervous, so I'm sorry. The reason that I chose this particular topic is because my daughter was born at 30 weeks, and they life flighted her to a separate hospital immediately after she was born, which meant that we had 48 hours where we weren't together, and it had a tremendous impact on me emotionally. And I noticed that for someone who comes from a lower income family, it had a huge impact on my life and the life of my family. So I know that there needs to be a more family-focused approach to the infants that are admitted to the NICU is essentially what I was trying to establish, but there's so much research done on such a wide scale that it needs to be honed in on different specific areas. Thank you. Yes. I'm sorry. No. I didn't, but because I was focused more on like the establishing almost the traumatic emotional experience of the mothers, it didn't get into that, but that's obviously something that needs to be looked into. I was surprised that on the parental stressor scale that low income families identified higher than the high income families, but that could just be, you know, an issue of being content with your care. They're used to having less, you know, subpar care. So that's what the research needs to dive further into those kind of things, I think. One thing that I have noticed is that like the fathers sometimes get brushed off a lot in the NICU because there's an infection control issue, and that's a super, you know, that's a valid concern. The nurses aren't super privy to encourage those attachments, and I think that would help a lot because the family unit is what needs to be in place to help the mothers navigate. Yes.
Did any of your NICUs in your research or literature review actually employ a stress counselor?
No, actually they didn't. There was one research study where the researchers employed it, but I didn't see anything where the NICU specifically was using that as an intervention, which is kind of sad to think about. Yeah. Thank you.
Okay.
There we go.
Is it gonna show the slides on here, or do I just have to do it up here?
You, the slide, I think the slides are going to be up there. I don't think there's a way to. Is there, yeah, is there like, hold on, let me.
If you click mid, and then if you hit minimize it off. And then you might have to click in here, Whitney, to be able to. There you go. Oh, no, you're okay. There you go. Okay, perfect. Okay. Hi, my name is Whitney McCormack. I'm going to do my presentation on early mobility in critical care patients. So if you don't use it, you'll lose it. It's a big thing that we talk about in nursing. The majority of patients that come into the ICU are those who have sustained life-threatening illnesses and or trauma, so they're not prepared to be there. And they end up spending an extended period of time in the bed. In such cases, the prolonged being restricted in the bed allows for undesirable effects over the body as a whole. So how does early mobilization of critical care patients impact overall patient quality compared to the prolonged mobilization or immobilization of patients admitted to critical care units? Research studies have shown positive impacts on various outcomes in critical care patients when early mobilization is implemented. So I looked at 6 different articles and gathered some data, and they all show the beneficial impacts of early mobilization in these critically ill patients. So a little definition for mobilization. Anybody that's a nursing student knows the book Iggy, and it defines mobility as an ability of an individual to perform purposeful physical movement of the body. So moving to the edge of bed, transferring from bed to chair, or doing range of motion exercises. So looking at the first article, early mobilization of critically ill patients in the intensive care unit, the systematic review and meta-analysis, researchers conducted an assessment on the evidence available with regard to the effects of early mobilization in critically ill patients. Evidence collected through an electronic database with randomized control trials composed of 2,308 critically ill patients concluded the following benefits of early mobilization on these critically ill patients. So they saw an increased number of patients able to stand and mobilize at discharge, as well as an increased number of ventilator-free days, and a decrease in delirium in these intensive care patients. Limitations that were noted in this article were difference in definitions of definitions in general, durations, and then treatment times. Contrary to this, the overall beneficial impact of early mobilization was noted in each study with the variations in the impacts. Our second article, Early Mobility in the Intensive Care Unit, Evidence, Barriers, and Future Directions, was a survey conducted by nurses actually on how critical care nurses are assigned with the implementation of practices like early mobilization of the critically ill patients to improve patient success overall. So the articles address the effects of immobility along with the challenges faced in achieving mobility since these patients are critically ill. Overcoming barriers to the early mobilization can begin with simple baby steps such as placing patients in the high Fowler position. Even though this isn't promoting mobility per se, it does allow for the core muscles to be activated, and it improves ventilation, and it exercises your diaphragm. There's newer technology coming into play. So there's different beds. Some that were noted in the article were VitalGo, a total lift bed, or a Catalyst bed. And you're able to strap patients in and help them actually stand up in a standing position. And it allows for fewer staff members to get these patients up and moving. Through this study, a similar conclusion was made that of the first article, that early mobilization achieves a positive impact on these critically ill patients, and it carries out a variety of factors that precede the patient even after discharging. The third article was early mobilization of mechanically vented patients. It's a nursing practice in Quebec in their ICUs. It played right into the direct role of nurses and the effects that we have on the early mobilization for these critically ill patients. They did a cross-sectional electronic surveying of nurses who worked in these ICUs to study early mobilization interventions along with nursing knowledge behind early mobilization of critically ill patients. 71% of these nurses in the study suggested that they were actually unfamiliar with scientific literature backing early mobilization of critically ill patients. On that note, the 89% correctly responded when assessing knowledge base of early mobilization of these patients and the benefits behind it. Some key factors were statements of like safety of early mobilization interventions, the effectiveness of range of motion, exercises, and maintenance of muscular strength, the effect of early mobilization on the mechanically vented patients during their stay, and the effects that it has on delirium. So the nurses that were included in the study shared their opinions on the time frame in which mobilization should occur, which is something that wasn't really touched on in the other articles. 67% of those stated that patients must be clinically stable before you attempt to start mobilizing them, while 56% said that mobilization should occur within the first 72 hours of admission. As stated in this study, the main intervention reported by the ICU nurses surveyed include having the patient sit on the side of the bed, like we talked about earlier, going from bed to chair transfers, and then range of motion exercises. Through the study conducted, the nurses displayed an adequate understanding of benefits as evidenced by literature, and this study allowed for a unique opportunity in raising awareness of early mobilization practices and allowing nurse-driven protocols to be implemented in the future. Article 4, Effectiveness, Safety, and Barriers to Early Mobilization in Intensive Care Units, supported the conclusion that overall positive impacts are associated with early mobilization. So through an electronic database, 56 studies were combed through and to outline the effects of early mobilization on critically ill patients. And through this database, the studies gained, suggested an increase in functional capacity over critically ill patients. So again, decrease in ICU acquired weakness, decrease in sedation needs, decrease in delirium, and increase in patients going directly home and not having to go to rehab. Article 5 moved to improve the feasibility of using an early mobility protocol to maximize ambulation in the intensive care and intermediate care settings, focuses on a practical use of a nurse-driven mobility protocol for critically ill patients to improve the amount of ambulation by patients within the first 72 hours. So through this action of multidisciplinary team members, a mobility order is set. You're including physical therapy, you're including occupational therapy, respiratory therapists, the nurses are driving this, and you have the doctors on board, of course, but you're working together to integrate one and the other to get these patients up and having them move before they get to the floor, before they go home, or before they need to go to rehab. There's positive conclusions drawn from this particular study. The only limitation noted was it was only carried out in one facility as opposed to multiple facilities. But it did show an increase in ventilator-free days and the patients going directly home again, as opposed to going to like rehab. And then the last article was ICU early mobilization from recommendation to implementation at 3 medical centers. They used a plan to study to act where the ability to compare and contrast the process implemented for early mobility program in 3 different ICUs and their impacts on clinical and patient outcomes. So again, they use nurses, respiratory therapists, physical therapists, the doctors. They actually had a specific doctor for the mobility, not just physical therapy and occupational therapy. And they made a nurse-driven protocol specifically for their ICUs to get these patients up and moving in an adequate time and in an appropriate form and fashion. So benefits to early mobilization, it's a decrease in ICU acquired weakness, decrease in delirium, decrease in the need for sedations, and decrease in ICU days. It also increases mechanically free ventilation days, and then an increase into home discharges. Again, not having to go to rehab and that sort of thing. One of the things that I found most interesting in this is a nurse-driven protocol, allowing nurses the opportunity to not only advocate, but regulate patient mobility and work hand in hand with other team members like physical therapy and respiratory therapy and occupational therapy to get these patients up and give them the most successful opportunity at getting back to a normal life. And there are my references.
Questions from the field?
I have a question.
Dr. Darby.
I have a question. Did you notice, did any of your articles state a specific scoring tool? Or
They didn't.
tool you could use?
They actually didn't, which is one of the things that like bothered me, because then you don't really have a good way to like reference it or to see like this one's doing better, you need to do this as opposed to this. I kind of wish they did. Maybe we can conduct our own survey.
We can just make a scoring tool to
Yes.
determine stability for early mobilization.
Mhm.
All right.
Thank you.
Good job.
All right, at this time, I would like to go ahead and introduce Maceyka, right?
Masika, I go by
Masika?
Macy. Yeah,
Amazing. Mastin, right?
Mastin, yes.
Mastin.
It's okay.
I apologize. I
It's
murdered
okay.
names. So anyway, at this time, she'll go ahead and begin. And judges, do you need another moment, or are we ready? Ready? All right, time people ready? We're all set?
All right. Hello, my name is Macy Mastin. So I did my symposium presentation on does music therapy reduce stress in college students? So my PICO question that we were supposed to come up with is, what is the effect of music therapy on the stress of college students? obviously as college students or anybody, we're stressed. So the population was college students. Then we did music therapy versus non-music therapy. We're not using music therapy. And then the outcome would be the improvement of stress. So what is stress? I'm very stressed all the time. As a nursing student, being a stay-at-home mom is very stressful. Everyone is stressed. It's not just a particular profession, anything like that. We're all stressed. So it's very individualized. Everyone is affected by it differently. Some people stress eat, that is me. And some people cry, they get happy, whatever. It just affects people differently. And so like I said, it's very individualized. We all go through it with school, work. It's like I said, being a stay-at-home mom, that's stressful too. Just life in general can be very stressful. So it can also start to affect your health, including your physical and your mental health. So what makes it unique? Well, it is a non-pharmacologic or a complementary approach to reduce stress. I mean, not just stress, but so you don't need a prescription for it. It's not a medication. It's inexpensive. So I don't know about y'all, but I use Spotify. Some people use Pandora. You can use Apple Music, things like that. And especially being a student, you can get it's like a discount. I think it's like half off. Like I pay $4.99, and I think that that's awesome to be a student. All you do is put in your email, your school email, and you get a discount just for being a student. And I think that goes to show that everyone who's a student mostly uses it. It's also popular today with technology. We know technology is just progressing every day, and it's portable, and everyone has a smartphone, I think, almost everyone. And so it's just easier to listen to music nowadays. Also, it's played everywhere. So I don't know about y'all, but I can't drive in my car without listening to music. I listen to it when I'm getting ready. I listen to it while I'm doing schoolwork. It just helps me focus. Me personally, I know some people it doesn't, but it's just very helpful. So my first article, it studied the combined effects of music therapy and aromatherapy. So I know it's not completely just about music therapy, but it also incorporates aromatherapy. So this can show that there are different things that we can do to decrease stress or things like that that aren't medications, therapy, things like that. So the groups were divided up into aromatherapy, music therapy, and then a combination of both to see which one decreased stress the most. Well, it showed that the combination of aromatherapy and music therapy showed the most decrease in stress among the participants, but it also did show that music therapy came in second. So, it's showing that it is important in decreasing our stress. All right, so my second article, it analyzed the effects of reed music on the stress of university students. I did not know what reed music was, so I had to look that up. But it is a different type of music with a certain instrument that's called a reed. It's more of a classical music. But there was a pre and a post test conducted that was before and after attending the reed music sessions. There were different sessions that you could attend. So you did a pre-test before you attended and then after. And evidence showed that there was a change from the pre-test to the post-test, showing that the reed music sessions did reduce the stress. And then also the more sessions that you attended, the lower your stress was decreased. All right, so my third article, it determined the stressors and coping mechanisms of nursing students at Shifa College of Nursing. So this one doesn't really pertain to, well, some of my articles don't pertain just to music therapy, but how people are stressed, especially since my topic is nursing or college students. It shows that students are stressed, so we need a way to decrease stress. So this was some nursing students, which I know it's college students, but nursing students are classified as college students. So this article shows that school is a major stressor in a student's life and how they cope with those stressors. some students, like I said, overeat, we cry, not always the healthiest coping mechanisms. The stressors that were caused were modified, and a lot of them had to do with the school itself. So starting training some of the faculty as counselors, needing somebody to talk to, things like that. So it showed that we do need a way of decreasing stress in these students. All right, so my fourth article, it was to examine the role of music as a potentially stress-relieving therapy among college students. So it was done at Southern California University, and it was done in a specific class, but over a different set of students from 2008 to 2013. And so they listened to a song by themselves, whatever they enjoyed, and then the professor played a song, and then they would fill out a survey about their stress and things like that. A lot of people said that music helped with their stress. Their stress was reduced. There were some students that said it didn't help, and it's not for everybody, and that's okay. But it's just, something that can work for a majority of people. This quote that I found just explains it perfectly. It says, the use of music therapy has been closely associated with relieving stress, anxiety, pain, and a myriad of other physical and or mental health diseases or disorders. So again, this one, my fifth article is not about music therapy itself, but the stressors and how people, like the major stressors in people's lives, so we can get to the bottom of it and see how we can fix it. So the purpose of this one was to systematically investigate the self-perceptions of emerging adult college students related to the effects that stress has on their lives. So there were 20 participants in a public university. They were asked to fill out a packet about their stress, which the thing that I liked about this specific article was it told me the different ages and male, female, things like that of the participants. And they weren't just 18 to 20-year-olds. It was, not just 18 to 24-year-olds go to college. People go back to college. And so it's showing that, it's not just young adults. So the four main stressors that came from this study were school, finances, personal relationships, and family relationships. I think that, we can all benefit. So the synthesis of the literature, a common theme that I found throughout the articles was that school is a major cause of stress. Music can help reduce that from the articles, what I've seen. Another common theme in the limitations is that the population size was too small or it had possibilities of gender bias. So especially the ones about nursing students, there are more female nursing students than male nursing students. So it's just kind of more on like the female population. So how is it relevant to nursing? Well, it's a cheaper alternative to therapy or medications. As we said, medications can be expensive, therapy can be expensive. Some people don't have insurance, and so they can't pay for these medications and therapy and things like that. So this is a cheaper alternative. It can be used for immunocompromised patients. With these patients, we don't want to, expose them to more people who could be sick, who could cause more infection, things like that. And then there's no allergies. Nobody's allergic to music. Do y'all have any questions? So it didn't say. Mostly I found that any music, because there's music for everyone. Some music that you like might not be my favorite, but there's something for everyone. And so that's why it wasn't just a certain type of music, it's just music in general. It showed that no matter what you listen to, because like in the music, the one about the nutrition class, throughout the different sets, they could listen to their own music. And then then the professor played a song. And so it might not be something they like, but their stress was still reduced because they also got to listen to their type of music. So no, not that specific one, but I think that either way, music just reduces stress in general.
Sure. I have 3 questions. So going back to my old band days, Bree instruments for like a saxophone and clarinet and those types of instruments. So is that what the article was talking about?
Yeah.
With saxophone sounds?
Yeah, it actually didn't go into what reed music was, so I had to go look that up, like outside of my article, because I was like, I have never heard of that before. And I thought it was probably an instrument, but yeah, so it didn't tell me what it was, I just had to go look. So, and there are my references.
At this time, I would like to remind everybody, please scan in on the QR codes if you're here for session 2. Taylor, I think you're the next one up. Let me get you situated here and we'll go from there. I'm still mastering this. Let's see if I think that's yours, right?
Yes.
Oh, wait, I did something wrong here. I think I was supposed to do this. There we go. Okay. All right. I'm going to go ahead and take the podium. Anything you need? Let's give the judges just 1 second here. So, I love that.
Lots of pictures of cute dogs.
Judges, do you need a few more minutes? No? All right. And how do you pronounce his name? Cole. Cole. Okay. Taylor Cole is going to go ahead and begin with her presentation.
So I chose to do my presentation over the effects of pet therapy on nursing home and assisted living residents. So obviously, when a person first goes into a nursing home or an assisted living facility, they can experience feelings of loneliness or depression because they're all of a sudden they're no longer with their friends or their family. They're just in a completely new environment that they're not used to. So they can sometimes isolate themselves and because they're not carrying on their typical social behaviors that they used to carry on. But pet therapy is a non-pharmacological therapy that does correlate to improved socialization and improved mood among these residents. And according to new research by the University of Texas at Austin, it's been discovered that elderly people who spent more time connecting with a wide range of people were more likely to be physically healthy, and they had a higher level of social and emotional well-being. So with that in mind, it's really important that nursing homes and assisted living facilities allow their residents to partake in adequate social interaction, and they promote the social interaction. So the purpose of my presentation was just to analyze 5 different articles and try to determine whether or not pet therapy had a positive impact on the socialization and just overall well-being of residents in these facilities. So my PICO question is, do nursing home and assisted living residents who utilize pet therapy have an increase in socialization and improved mood compared to residents who do not utilize pet therapy? So the population of my research was the residents within these facilities. The intervention was the utilization of pet therapy. And the 2 things being compared were residents who used pet therapy versus residents who did not. And the outcome that we're hoping to see was an increase in socialization and improved mood. And if there truly is a positive correlation between these 2 things, then nurses who work in these types of facilities can use this information to just enhance the lives of the residents that they work with. So my first article was entitled Pet Therapy, an Effective Strategy to Care for the Elderly, an Experimental Study in Nursing Home. And the research design was an experimental longitudinal study. And the purpose of this article was to confirm the effectiveness of animal therapy in improving the well-being of people within a nursing home. So this study took 28 participants, and they were randomly split into 2 groups of 14. And both groups filled out the same questionnaire, but only one group actually spent time with a dog in 1-hour sessions twice weekly. So some strengths of this study was the randomized groups and the consistent questionnaires throughout both groups. And a limitation was that it was a pretty small sample size and that it was a pretty short length of study. But the results of this study did find that the experimental group who was exposed to pet therapy, they were more social and built more personal relationships. So if they were shy and more reserved prior to this, they started participating more in like the activities and everything that they had within the facility. And this is obviously relevant to my proposed PICO because it demonstrated that pet therapy can improve the mood and socialization of the residents. And so my second article was entitled Relationship of Behavioral Interactions During an Animal-Assisted Intervention in Assisted Living to Health-Related Outcomes. And this is a longitudinal secondary data analysis. And the purpose was to determine if animal-assisted therapy had an impact on depression and physical activity levels in patients in assisted living facilities. So for this study, they took 22 residents from 4 different facilities, and they did activities such as feeding, walking, playing fetch, giving treats, just doing different like training commands, that kind of stuff with dogs in multiple sessions to encourage the residents' motor skills and as well as social skills. And the mood and physical activity were assessed using various tools over multiple months. So the strengths I found in this study was the length of study. Like I said, it was over multiple months. And they used various assessment tools to look at the results. Limitation was, it was once again a small sample size, and there wasn't a whole lot of gender or ethnic diversity in this study. And there were just a lot of variables because one group might be feeding a dog, the other group might be playing fetch. So, and it just changed. So that was obviously could skew results. But so like I said, the results varied from person to person, session to session. But when they averaged the results, they did find that pet therapy is beneficial for these people. And they concluded that pet therapy positively impacts the patient's mood and activity level. So once again, the nurses can just use this information with their residents to improve their social interaction. Third article I looked at was animal-assisted therapy and perception of loneliness in geriatric nursing home residents. This is an experimental study, and the purpose was to determine if animal-assisted therapy reduced feelings of loneliness in nursing homes. So the sample size of this study was 21 people from one nursing home. It was 17 women and 4 men, and they volunteered for a 6-month-long study. And they participated in 90-minute sessions 3 times a week. And they used the UCLA scale of loneliness and patient questionnaires to determine results. So the strengths was the 6-month time frame and the 2 different methods of interpreting results. And again, small sample size, and it was way fewer men than women. And there also wasn't a control group, so you really didn't have anything to compare to. But the results of the study were that by spending time with the animals, the residents experienced fewer feelings of loneliness. Their social behaviors were just enhanced and improved. Fourth article, Natural Healers, a review of animal therapy and activities as complementary treatment for chronic conditions. This is a systematic review, and the purpose was to analyze 18 different articles to determine if animal-assisted therapy has a positive impact on patients with chronic conditions. So the sample of this study was determined using strict inclusion and exclusion criteria, and the phrase animal-assisted therapy itself was given a very strict definition, just so they had something to compare all the articles to, so they were all met the same standard. So they started with 31 articles, but after going through all those criteria, they found that 18 met all the required fields. So they just analyzed and compared those 18 articles. So the strengths was, like I said, the strict inclusion criteria and the number of articles that were being compared. And the limitation that this article talked about was how they didn't really have a whole lot of information on pet therapy with children. However, because the population of my PICO question was more on the geriatric side, that limitation really didn't affect my
presentation. But like I said, they did find that it helped people with chronic conditions just be more social and interact more with the people in the facility around them. My fifth and final article was entitled Effects of Animal-Assisted Therapy on Behavioral and/or Psychological Symptoms in Dementia, a case report. And the research design was a quasi-experimental longitudinal study. And the purpose was to gain more knowledge on how animal-assisted therapy impacted someone with dementia during an 8-week study. So for this one, the sample size was just one individual that was diagnosed with vascular dementia. And she was prescribed with animal-assisted therapy in hopes of reducing her psychological symptoms. The strengths were that they used 5 different tools to determine the effectiveness of the therapy. And obviously a limitation, it's only based on one participant, so that was obviously a limitation. But the results did conclude that this individual was more cooperative with the staff. She had an enhanced quality of life. She also had enhanced activities of daily living. So I felt like this was relevant to my PICO because obviously like there are quite a few dementia patients that are within nursing homes. So by exposing them to pet therapy, they can, their ADLs will be enhanced and just their overall quality of life improves. So just to briefly recap, the purpose of this study was to nursing homes and assisted living residents becoming lonely, depressed, and less social. And my proposed PICO was, do nursing home and assisted living residents who utilize pet therapy have an increase in socialization and improved mood compared to residents who do not utilize pet therapy? So I did find numerous common themes within these articles, and they all concluded that it was beneficial in some form or fashion. Some were just, they were more social. They had enhanced quality of life, enhanced ADLs, but the common theme in each article was that it was beneficial in some form or fashion. And also like a common weakness, like I kept saying, small sample size. So I feel like it would have been even more reliable if we had looked at more residents within each study. But this is relevant to nursing because obviously, like I said, nurses who work with these residents can use this information to just overall better the lives of the residents that they work with, and just help them be more social and just happier. So in conclusion, I feel personally that there is, based on the studies analyzed in this presentation, that there is enough evidence to support the claim that pet therapy does improve the socialization, mood, and loneliness of the residents. And I feel like if nurses started incorporating this therapy more often, then the lives of the residents that they work with would be significantly improved if this were to become part of their routine practice. And these are my references. I broke it. Right.
During your research, whether you found out whether they have participants that have either early phase of Alzheimer's or late phase dementia, and whether those individuals could be included in any type of studies.
And one of, I can't remember exactly which article it was, but it did look at, well, obviously the 5th article was a dementia patient, but some of the other articles looked at people with mild or moderate cognitive impairments. So they didn't go into detail about like what specific diagnosis they had, but that was included in one article that it benefited those people with mild or moderate cognitive impairment is the way the article worded it. Well, right, a lot of them, the articles, they like did screenings prior to starting the study. So if someone, like I said, had a fear of animals or they had like a severe allergy, they were automatically like excluded from the therapy. So it was just based on people who were like willing to participate and didn't have like a pre-existing fear or allergy. All the ones I found used a dog. Some of them just used the one, some used multiple, but every study I personally saw was the use of a dog. Agree. That sounds fun.
Thank you again. Let me get the system working again and give the judges a moment. Let's see. Oh yeah, you're fine. I don't know why I did that. Here. And switching. I think I've got it. There's the pet one. Where'd yours go? There's on the screen. 1 second. Just trying to see what's exactly going on here. Let's see what we've got here. Did it? No, it should. Let's see, go big. I don't know what it did, it must have glitched. Yeah, let's close that.
I think it just left that.
Make it large. All right, so where are we here? So that's
option or stop share on the screen.
yeah, so there's PowerPoint slide. There it is. Let's see that one. Okay, so this was the end of it. So let's end that.
There we go.
Screen sharing is stopped and shared window is closed. Okay, that's what we were after. No, wait, don't go away because we haven't make absolutely sure that we've got to share again. Okay, let's see, let's go share screen. And then we're there, she is, no.
Is this?
No.
Let's go.
Let's just go back
Close out
and,
of share
yeah, just
screen.
go find it again.
Yeah. Minimize this real quick. Sorry.
Okay.
Close this one. Let's close all of them maybe and see if that'll help.
Let's not close that
We can
one.
just minimize that and then try to get back to our folder is what we want.
Yeah, so that's the only reason. So there's hers. So there it is.
Okay, so do present.
That's what we're probably missing. There we go.
And then let's go back into here. And do share screen.
Well, that's what's so weird. That's a share screen.
And now you should be able to select that one.
That's how that works.
And we should be good. There we
And
go.
but we still have him.
we
Let's just
can
minimize
click
them.
on the,
No?
we can just click on here, the two. We're just seeing
Yeah,
you.
yeah,
instead of us.
why do we have you?
Click on the two, oops, there you go. Yeah, now we can at least see her on the screen.
Yeah.
You're just getting in there.
Yeah, we don't know how you got there, but you're there.
Are you good?
Okay.
So this,
And we're recording, just so you know, we're still recording. So. And that's the one we want to go on. Miss Dutton's all set. There she is. So that's that one.
you can do this, it'll be just that.
Okay.
So you should be ready to go. That's just showing me I'm logged in.
Okay.
I've just been logging in different ones and checking them.
Checking in,
Just to
okay.
make sure.
All right. So we're all good. Okay. So thank you. This is the last one of session 2. So yeah, we were not going to get through here unscathed. So Bethany Dutton is now getting ready to present. Judges, do you need another moment since you had to come help with the IT? You all good? All right, at this time, whenever you're ready. Okay. Thank you so much.
Hi, everyone. I'm Bethany Dutton. I'll be comparing Eat, Sleep, and Soul to Finnegan neonatal absence scoring system for neonatal absence syndrome infants. These are the key concepts I'll be going over. First, what is neonatal absence syndrome? Short, NOS. NOS is a syndrome in which an infant has withdrawal symptoms due to exposures such as opioids during the fetal stages. Symptoms include tremors, seizures, poor feeding, fever, sweating, and breathing problems. So what is Eat, Sleep, and Soul? It's yes and no questions that were asked about the infant to assess the critical functions of living. Question examples include, does the infant eat poorly due to NOS? Yes or no. Did the infant sleep less than an hour due to NOS? Yes or no. And is the infant unable to console within 10 minutes due to NOS? The interventions for Eat, Sleep, and Soul are done differently at each hospital. Next, what is Finnegan neonatal absence scoring system? It was created in 1970s by Dr. Finnegan and her colleagues to provide universal care for NOS infants. A nurse gives a number score to determine what actions are taken. Some example scores are 2 points are given for a high-pitched cry, 3 points are given for a high-pitched cry lasting longer than 2 hours, 1 point is given for sweating, and 2 points are given for poor feeding. The higher the points, the more interventions performed. Once the score is above a set point, specific interventions are taken, such as drug administration or placement in the neonatal intensive care unit. The scores at which each intervention is taken is different at each hospital. The first article I looked at is a novel approach to assessing infants with neonatal absence syndrome. The purpose of this article was to compare the Eat, Sleep, and Soul approach with the Finnegan neonatal absence syndrome or scoring system, short FNOS. The population was 50 substance-exposed infants at the Yale New Haven Children's Hospital. The strength of this article was to accomplish this, they implemented the Eat, Sleep, and Soul approach practice while also giving the infants Finnegan scores. The limitation of this study was a small population size. The results of this study showed that only 12% of infants were treated with morphine using the Eat, Sleep, and Soul approach compared to 62% that the Finnegan suggested needed morphine. The relevance of this article was that it examined both Eat, Sleep, and Soul and the Finnegan scoring system. My second article is Eat, Sleep, and Soul approach, a family-centered model for treatment of neonatal absence syndrome. The purpose of this article was to critically review and summarize the research done on the Eat, Sleep, and Soul method of managing neonatal abstinence syndrome. The population was 577 infants across 3 different studies. The strength showed the common themes in all of the studies. Limitations were that researchers contacted the medication treatment center of the mothers to assess the appropriateness of the mother's doses. This altered the internal validity. If they had not contacted the treatment center, the course of events for the family might have differed. The study was also limited because there was limited research on adverse outcomes such as hospital readmissions, abuse, and neglect. The result of this study showed that Eat, Sleep, and Soul decreased overall costs, reduced length of stay from 17.4 days to 11.6 days. It decreased exposure to pharmacologic agents from 87.1% to 40%, and there was an increase in caregiver presence from 55.6% to 79.9%. My third article is Parents' Perspective on Eat, Sleep, and Soul approach for the care of opioid-exposed infants. The purpose was to get parents' perspective of the treatment of infants when using the Eat, Sleep, and Soul method. The population was 18 parents of neonatal abstinence syndrome infants. The strengths of this article was that it used open-ended questions allowing parents to answer sincerely, and that the interviews were recorded and reviewed by 3 separate nurses. Limitations of this study was population size and the race and educational background of the parents. Majority of the parents were white and had a high school education. The results of this study showed that parents appreciated fewer interventions with Eat, Sleep, Console, felt encouraged by the treatment and nurses' attitudes towards them and the infants, but the parents did perceive gaps in communication, and parents expressed need for increased support due to experiencing negative emotions related to infant diagnosis. My 4th article is a reduction in length of stay and morphine use for NOS with the Eat, Sleep, Console method. The purpose of this article was to discover if Eat, Sleep, Console reduced the length of stay and morphine use in NOS infants. The population was 76 infants. The strength of this study was that a multidisciplinary task force reviewed the care of the infants. This task force included physicians, a newborn nursery provider, and a pediatric pharmacist. Limitation was the population size. Another limitation was the majority of the infants were exposed to nephrin in utero, which has fewer adverse effects. The results of this study showed that length of stay of infants decreased from 10.3 days to 4.9 days with Eat, Sleep, Console. Infants treated with morphine decreased from 92% to 9%, and doses of morphine given went from 38 doses per infant to 0.3 doses per infant. The relevance of this article is that it talks about the reduction of morphine use in the NOS infants when implementing Eat, Sleep, Console, which improves outcomes. My last article is Escaping the Finnegan, Is It Time? The purpose of this study was to examine alternatives to the FNOS that are simple, objective, pragmatic, and most importantly, subject to external validation. The population size was 2,072 infants that were looked at between 11 different studies. The limitation was that they stated only 3 of the studies had large enough population and undergone external validation to be valid. So majority of the studies looked at had a small population. The results of this study showed that further research needs to be completed. It also states that similar outcome improvements have been shown after the implementation of non-pharmacologic care practices while using FNOS. The relevance of this article was that it was critical of Eat, Sleep, Console. It said that there was not enough research on Eat, Sleep, Console to say it improved outcomes because the population sizes were too small. Okay, now on to discussion. The Eat, Sleep, Console approach does improve outcomes such as reducing length of stay, reducing pharmacologic use, and empowering parents of neonatal absence syndrome infants. There's not yet enough definitive data to say Eat, Sleep, Console is the best approach for long-term outcomes, as this was not looked at in any of the articles. And as we saw, limitations for majority of the articles was the population size. So why was this research necessary? Authors Stein and Davis of Escaping the Finnegan, Is It Time article said it best: a validated, simple, clinically relevant, and universally accepted approach to assessing opioid-exposed neonates would facilitate high-quality clinical care. To simplify this, an approach that is simpler, valid, and accepted universally would improve the clinical care of NOS infants. In conclusion, Eat, Sleep, Console reduces the length of stay, reduces pharmacologic use, and empowers parents of NOS infants in the short term compared to Finnegan. But as I said with the article Escaping the Finnegan, Is It Time? They state that similar outcome improvements had been shown after the implementation of non-pharmacologic care practices while using FNOS. More research needs to be performed to conclude the long-term effects of Eat, Sleep, Console on neonatal absence syndrome infants. Currently, there is research in progress being done by the Environmental Influences on Child Health Outcomes Program. Several facilities are implementing FNOS and Eat, Sleep, Console, then evaluating short-term outcomes with a 2-year follow-up to evaluate neurodevelopmental outcomes. The research will be completed in November of 2022. That's my references.
One of your articles referenced the parents, as in like both parents, and just from my very minute neonate experience, with situations like this, there was typically one parent there, and it was usually the mother, because a lot of these relationships were dysfunctional, related to opioid abuse and effects on the baby. So, did they mention anything specific about the parental involvement? Or?
They didn't in any of the articles. I never saw whether it was one parent, two parents. They just always said parents.
All right, well, thank you very much. Appreciate it. At this point, session 2 for room 313 has concluded. I will give my judges a few moments, but I would like to thank them very much for judging today. I would also like to thank Whitney very much for running the numbers for us for sessions 1 and 2. And one last call to please, if you've been to the session, don't forget to scan your QR code. And we do have quite a few programs up here, so I strongly suggest to the presenters to go ahead and get the program to present. And anybody else that would like one as well can possibly go on to the other sessions. It's my understanding the next round of sessions will begin at 2:25, if I remember correctly. So go ahead, freshen up, take a stretch, and we'll look forward to seeing you in the next session. Thank you.
Open up Emily's stuff here. I'm going to try to open Emily's stuff up. Chris, you may have to come back in again. It's doing the same thing. Let me grab Chris because he had this issue earlier.
Just take a picture all the way across
Okay.
to watch it. So we come up and screen here.
Okay.
See it behind us.
Yep.
So,
Because I hit record.
yeah, so it's recording. And if you want to just share screen, have you already opened her PowerPoint?
I have no.
Okay, so it's this one?
Yep.
All right. So open it. We'll make sure there's no enable content there. You just want to start it. And
Because I've already hit record.
yeah, we stopped sharing though. So we'll just share this screen. And what you'll do is once you get done here, sorry, I lost my. We'll go to this one and do that one. Okay. So all you have to do is that's up there and see how you go to the far right.
Okay. It will allow me to stop sharing.
And then you can stop sharing.
Okay.
Perfect.
All right.
Thank you.
All right.
Okay.
Thank you.
So I'm going to introduce Emily Oldham. She's here to present for us. And then just a few reminders for the room. Strawbridge is here. She's going to be our timekeeper, and she will let you know when you have 5 minutes left,
Okay.
and then 2 minutes left, and then when it's time to call it quits. And then if you have come in late and you haven't scanned in your QR code, please make sure to do so. There's some papers on the end of the table. So thank you. You take it away.
Hi, my name is Emily Oldham, and I'm a senior nursing student here at Piedmont University. I chose to do my presentation on animal-assisted therapy in pediatric oncology patients and their families because I currently work at and I'm completing my senior practicum placement at Children's Healthcare of Atlanta in the pediatric ICU. We have therapy dogs there that come in and out quite frequently, and I've seen the impact these dogs have on our patients. We see a wide range of patients in the PICU. Therefore, I have narrowed down my research to specifically pediatric oncology patients. As you can see, we have a picture of Tidings up here. This is our therapy dog in the PICU. My PICO question is as follows. In pediatric cancer patients and their parents, what is the effect of animal therapy compared to not having animal therapy on stress levels? My population is pediatric cancer patients and parents. My intervention is animal-assisted therapy. My comparison is not participating in animal therapy, and my outcome is reduced stress levels for patients and their parents. Why is animal-assisted therapy important? Hospital stays can be traumatic for us, and imagine what it's like for a child. Being away from their usual routine of school, sports, and family can cause stress. This stress not only impacts the child, but also the parents, guardians, siblings, extended family members, and even the nursing staff. Therapy dogs bring the sense of home, happiness, safety, and companionship in the hospital for these patients. Article 1 is titled Pilot Study of Therapy Dogs for Inpatient Youth with Cancer. This was a pilot study randomized trial. So if you don't know what a pilot study is, it's a very small study done to evaluate the outcome, the cost of the study, and overall design so that the proper improvements can be made before starting the larger study on the same topic. The limitation of this study was that there was no control group. So this means that each participant received animal therapy. The strength was how they collected data. One data collection method that was used was surveys. Patients completed various surveys such as the distress thermometer, PROMIS, which is short for Patient Reported Outcomes Measurements Information System, and the PEDS-QL Present Functioning Scale. Direct observation of the therapy dog visits were also used, and that proved to have the greatest outcome. As seen on the Article 1 handout that I passed around, 100% of patients and 89% of parents were eager to see the dog. 95% of parents and patients smiled around the dog, and 100% of patients and 74% of parents appeared to be more relaxed. The chart breaks down more interactions and behaviors and puts them into percentages, as you can see. The PEDS-LQ survey showed significant decreases in worry and tiredness, with changes as well in fear, sadness, and pain. The nurses reported that it was easier to interact with the parents after the therapy dog visit. This study is relevant to my PICO question because general distress of being hospitalized decreased, and parents reported that with the therapy dog, that was the first time they had seen their child smile since being admitted. Article 2 is titled Measuring the Effects of an Animal-Assisted Intervention for Pediatric Oncology Patients and Their Parents, a multi-site randomized controlled trial. Since this was a controlled trial, not every patient got to experience animal therapy. The limitation of this trial is that it took place at multiple hospitals at once. The researchers reported that it was challenging keeping track of all the participants and the results of the questionnaire. The strength of this trial was the use of the Pediatric Inventory for Parents questionnaire because it had the greatest outcome. For the patients, they used the PEDS-QL survey, which assessed pain, nausea, anxiety, and worry. For parents, they used the Pediatric Inventory for Parents questionnaire. They also measured each patient's blood pressure and heart rate before and after each session. Parents in the intervention group reported on the questionnaire that they experienced significant reductions in parenting stress. Both patients and parents in the intervention group reported a reduction in the frequency of stressful events related to admission. As for blood pressure and heart rate, the control group had no changes over time. The intervention group, however, showed a slight increase in blood pressure and heart rate, but this was most likely due to the patients playing and interacting with the dogs during the sessions. This article is relevant to my PICO question because therapy dog sessions proved to decrease stress related to medical care in all aspects. Article 3 is titled Canines and Childhood Cancer Pilot Study Report. The study was a randomized controlled pilot study. The limitation of the study was that some of the data collection methods used, such as the observational scale of behavioral distress chart, were not as effective as thought to be. The observational scale of behavioral distress is used to determine child stress during invasive medical procedures. So since the patients weren't going through any invasive medical procedures when visiting with the therapy dogs, this method was not completely accurate. The strengths of this article was that they took the stress of the therapy dogs into consideration as well, and they measured cortisol levels in the dog's saliva to ensure that they were not getting too overstressed. The state trait inventory survey that was completed by the parents at the beginning and the end of the trial showed a decrease in anxiety in the intervention group and no change in the parents of the control group. The Pediatric Inventory for Parents survey was also used. It showed a significant decrease in distress during hospitalization. Parents said they had the most stress during chemotherapy, and they reported that when the therapy dog visits, that they felt less stressed. This article is relevant to my PICO question because it proved that visiting with the therapy dog resulted in less stress and anxiety during cancer-related treatment. Article 4 is titled Impact of an Animal-Assisted Therapy Program on Physiological and Psychological Variables of Pediatric Oncology Patients. This was a quasi-designed study, meaning that this study is trying to establish a cause and effect. The limitation of this study was not using a control group. It also had a small sample size and only had participants that were diagnosed with acute lymphoid leukemia. A strength of this article was that the researchers worked closely with the nosocomial infection control team within the hospital. Multiple surveys were utilized to collect data. These include the Quality of Life Evaluation Scale, Brunel Mood Scale, Child Stress Inventory, and FACES Pain Scale. These surveys were used before and after visiting with the therapy dog. They showed significant improvements in pain, irritation, and stress. This can all be seen on the Article 4 table that is titled Patients, the one that I passed around. There also was reported to be a slight decrease in depressive symptoms among the patients. For parents, the State Trait Inventory and Brunel Mood Scale was used. There was a significant improvement in anxiety and mental confusion in the parents. This can also be seen on the second one for Article 4 titled Parents. This article is relevant to my PICO question because animal-assisted therapy proved to be a therapeutic method that had a positive effect on psychological factors in patients and their parents. My last article is titled Assisted Therapy with Dogs in Pediatric Oncology, Relatives and Nurses' Perceptions. This design was a qualitative study. The limitation of the study was that there was a limited number of trained therapy dogs to participate in the study. A strength was that everything was strictly observational based and no surveys were used. If you refer to the paper I passed around for Article 5, you can see that the patients were asked to describe their pain before visiting with the dog and after. The responses in blue were positive results. The ones in pink were no change, and the one that's in yellow was a negative or worse response. In addition to observing reduced pain for many patients, researchers also observed reduced heart rate, blood pressure, and respirations, which indicates relaxation. When asked about the visit, parents and nursing staff said that it made adapting to the hospital environment easier and reduced anxiety. This article is relevant to my PICO question because it proves that the presence of dogs makes children more comfortable around nurses and doctors, which in return calms the parents. Some common themes present in each article were that most patients and their parents felt stressed and worried before meeting with the therapy dog. Stress and worry seemed to decrease tremendously when in the presence of the therapy dog, and visiting with the therapy dog led to enhanced communication between the patient, parent, and the nursing staff. It is very evident that human-animal relationships play an important role in healing and emotional support. How does animal-assisted therapy impact nursing practice? It positively impacts patients and their caregivers emotionally, physically, and psychologically. Therapeutic communication is enhanced, and I can guarantee if you have an animal at home, whether that be a dog or a cat, that they provide you with support, comfort, and companionship. So why not put that same comfort and companionship into every single patient care facility? The dogs would provide emotional support for parents, patients, and the nursing staff. Does anyone have any questions? Katie? So I think, I know at CHOA, they only use dogs due to infection purposes. There's probably other groups out there that use other animals, but I know primarily in hospitals due to infection reasons that they just use dogs. Dr. Huff? Yes, so each dog has a handler that actually owns the dog and puts it through therapy dog training as a puppy. So they are equipped to be in the hospital and they're not vicious or aggressive towards patients because they've gone through those trainings. Thank you.
Anna? This is Anna Morton, and if you have not scanned in on the QR code for just joining us, please do so. Yes, we went through it to see if we could find something earlier, so you may.
I can look it up too. Oh, maybe I shouldn't. I can pull it up on here.
It may click to it, but
Just in case.
yeah.
It might be on the second page.
Inside of the PowerPoint, you hit Control Select on your slide and right now is waiting for it. Okay, I mean, once you have.
Once I do it, okay.
Like, presenter.
Okay.
Could you find it in case? I
No.
thought I saw her somewhere.
Mm,
Yeah, let me see if it'll open.
yeah.
It's gonna work.
Okay.
So just hit-
Okay. Oh, cool. Sorry, everyone. Let's go back. Look at that.
Oh, okay, so this is it.
Okay. Hi, I'm Anna Morton. I'm a senior nursing student here at Piedmont, and today I'll be discussing how music therapy helps shorten a patient's length of intubation. So the PICO question I've chosen here is, in intubated patients, how does music therapy affect the length of time a patient is intubated in comparison to a patient that did not receive music therapy? My P, which is my population, is intubated patients. My I, which is my intervention, was music therapy. My C, which is comparison, was normal intubated patients' length of intubation versus intubated patients that had music therapy provided during lengths of intubation. And my O, which was outcome, was the overall shortened time of intubation or decrease in stress. So first and foremost, what does it mean for a patient to be intubated? In its simplest form, being intubated means having a procedure done where a tube is placed into your throat down into your lungs. This procedure is used in a patient that is no longer able to supply adequate gas exchange to their body and needs assistance from a ventilator to keep them oxygenated. This procedure is done in the majority of general anesthesia required surgeries. So anytime you've gone under the knife, you most likely had this done. Sorry. This procedure can, however, do more harm than good if used for too long. If an ET tube, which is the tube that is placed and used in intubation, is left in for too long, it can cause many unfavorable side effects, including necrotic uvula and vocal cord granulomas. Necrotic uvula and vocal cord granulomas have side effects that can take upwards of 4 to 12 weeks to heal, with symptoms like breathlessness, loss of vocal range, loss of voice, and of course, pain. However, in many cases, this procedure is inevitable. So even though you already saw the gruesome picture, here is a blood and trauma warning. So if you're not good with blood and trauma, even though I already made you look at it, you might not want to look at the next slide. Sorry, again. So although intubation can have many negative effects on patients, it is still one of the most crucial procedures we have to date to bring patients back from the brink of death. As you can see, this patient has very severe facial trauma that compromised his chin, mouth, and most importantly, his airway. An ET tube was placed at the scene and potentially saved this man's life. Therefore, if intubation is so important for many patients like the one I just showed, how do we reduce the negative effects that can come from such a life-saving procedure? This video goes in depth on how Sue Wood, a certified music practitioner, is using the art of music to keep Loyola University's medical center intensive care patients calm and in a healing environment. I don't know how loud it's going to be. It's not playing on here. Can you? Anyways, she's just basically going through how effective it is, how it calms her patients, how even when sedated, the patients still find enjoyment through it, and they show decreases in vital signs through heart rate and blood pressure. And then she basically just talks about how they can decline the service if they would like, but many of the times when they do accept it, they feel much more relaxed and feel much better afterwards. Oh no, it wants to work. Okay. Okay. So what really makes music therapy such a good asset in these patients that are intubated? Well, as you can see, listening to music causes the brain to release dopamine, which is a feel-good chemical. Music acts as a distractor, focusing the attention away from negative stimuli to something pleasant and encouraging. Music has the ability to alter breathing and heart rate. This is so important for an intubated patient that needs to let the ventilator work for them and not work against it. Music also has the power to improve your state of mind. This helps keep things like depression and anxiety at bay. Music can help reduce this perception of pain, which is again so important when intubated. Music can alter the patterns of pain, depression, and disability. Music occupies the mind with something familiar and soothing, and music with a strong beat can stimulate brain waves. Slow beats encourage the slow brain waves that are associated with hypnotic or meditative states, and faster beats can encourage more alert and concentrated thinking. I know what you may be thinking. If these patients are intubated, can you even hear the music in order to achieve the positive effects? It has been shown that patients that have been asked post-intubation how much they could hear during sedation remember many conversations that were had with their family members and colleagues. Now I'll move on to the articles that I used to help justify my thinking. This first article was the influence of music during the mechanical ventilation and weaning from mechanical ventilation, a review by Brianna Hetland. This study had 612 patients divided among 16 studies. The purpose was to show the correlation between music therapy and decreased effects of mechanical ventilation and promotion of effective weaning. So why was the study so effective? The study not only compared the effects of music therapy, but also the effects of different types of music. And in result, this article showed that the use of mechanical ventilation helped reduce the number of sedative medications needed and showed a higher sedative score, meaning they were in a deeper state of sedation. This next article I chose was a systemic review of interventions to facilitate extubation in patients difficult to wean due to delirium, agitation, anxiety, a meta-analysis of the effects of dextromethorphan. This had a total of 303 patients that were studied in this systemic review. The purpose of this study showed the relationship between a different sedative medication and their improved effects of intubated patient sedation. So why was this study so effective if I was talking about music therapy? Although this study was more based on medications versus non-pharmacological therapy such as music therapy, I was able to use the vital signs with different medications provided and compare them to my music therapy patients. And I found that with my music therapy patients that used music therapy in conjunction with sedative medications, their vital signs such as heart rate and blood pressure were much lower than just sedative medications alone. In result, this article provided evidence that dexmedetomidine was the best medication to use in intubated patients to prevent delirium, agitation, and shorten intubation time. The relevance of this article, again, was I was able to use the article as a comparison piece for my music therapy intervention. This next article that I used was the experience of music therapy during the weaning process of patients receiving invasive mechanical ventilation by Stephanie Morris. This study was 43 qualitative studies comparing 30 minutes of music therapy versus 60 minutes of music therapy. This article showed a split analysis to observe the difference in relaxation in mechanically ventilated patients that are provided 30 minutes of music therapy allowed versus 60 minutes of music therapy in headphones. The study was so effective because it gave me a deeper look into what methods of music therapy is most effective and provided me with the best evidence to move forward with my analysis to narrow down the best form of music therapy. In result, the study showed a great decrease in anxiety and awareness of the intubated patients that was shown through decreased heart rate and motor response. The next article I used was the effect of two music therapy methods on agitation and anxiety among patients weaning off mechanical ventilation, a pilot study. This had 6 patients that were examined in the pilot study. Participants were studied to see if their preferred type of music was provided, if it affected their experience and length of time intubated. Why was this study so effective? The study was so effective for me, for my analysis, because in small groups of 6 people causing it to be a very in-depth review of their reaction to music therapy and whether they reacted to a random choice of music versus their preferred choice of music. The study showed that music therapy does have a therapeutic effect on intubated patients. However, it also showed that specifically had a positive effect on patients that got to listen to their preferred genre of music. And then finally, I believe I have the effect of nature-based sound therapy on shortening lengths of mechanical ventilation and coronary artery bypass graft surgery patients during the weaning from mechanical ventilation. This was 120 patients divided into 2 control groups of 60 with different interventions. The study mainly looked at the effects on an intubated patient's anxiety and how that affects their intubation and healing time of their surgical scars. This study gave me a more in-depth look on not just the effects of music therapy on intubation, but also healing with their surgical scars. So this study showed me that not only does it help them healing internally, it helps them heal externally with their scars. The results indicated a statistically decrease in patients' anxiety through mechanical ventilation process with the use of calm, mature noises. The relevance of this study, this article gave me an insight on all the music therapy does show a positive effect on anxiety. It does not show a great effect in aspects of weaning days. And then these are my references. Thank you guys so much for listening. I hope you got a better insight. Does anyone have any questions? Emily?
Did you find that through your research, music out loud versus headphones was more effective?
So through my research, I found that headphones were more effective, which I think makes sense. It's more internal. They can block out the other noises rather than just out in the open. And then I also found that music in headphones with their preferred music genre had the best outcome. Katie? So typically a patient, it depends obviously, but typically a patient is intubated for 1 to 3 weeks. And of course, the longer, the worse the effects. Yeah. Thank you.
It's been a minute since I've had the call. We're used to it.
All right. Sorry, I had to pause for my photo op. All right, my name is Kaylee Robertson. I'm one of the senior nursing students here at Piedmont, and I'm going to talk to you today about the mental health crises in nursing students. So first off, I don't want to single anybody out, y'all are, don't make me think that, but raise your hand if you've ever experienced any stress or anxiety. Because if you haven't, I might need to talk to you after the presentation to see what you do, because I'm experiencing both right now. So in order to discuss mental illnesses in nursing students, we first have to discuss the difference between mental wellness or mental health and mental illness. So according to the World Health Organization, your mental health allows for the ideal physical, intellectual, and emotional development of an individual. And so this is achieved when an individual recognizes their own potential, can cope with the normal stressors in life, and they can contribute actively to society. So some characteristics of good mental health would be that you can identify fluctuations in your own mental status, you feel good and satisfied, and then a sense of belonging and being able to deal with the circumstances that life throws at you. And while we have mental health, on the other side of the continuum, we have mental illness. And that arises when there's alterations in your intellectual and your emotional development in that individual, and they can't cope with the stresses of life any longer. And so examples of these mental illnesses can include depression, anxiety disorders, eating disorders, addictive behaviors, and personality disorders. So I found this little graphic with the help of Google, and it says, my plans for Friday night, I'm just hanging out with my friend Florence every weekend until nursing school is over. And I can absolutely attest to that fact. I have not had a social life for the past 2 years, but I wouldn't trade it for anything. Being a nurse is amazing, and I'm so excited. But what makes nursing school in specifically so stressful, and the mental health disorders in nursing majors are often due to the rigor or the difficulty of the curriculum that we study,
and having to acquire these skills in labs and clinical settings and practical exams that all contribute to an exceptionally complex learning environment. And then along with the rigor of these programs, some students might have also had a career before they started nursing school. So you might actually have a job in school, and some people have kids and husbands and wives and things like that. So it make things very stressful, and then just on top of the normal stressors that we have in life, it can be very difficult. And this is a little bit personal for nursing students, but what kind of test are you going to take in college that has 4 answer choices and one of them is the most correct, but all of them are correct? So my question was, are nursing majors more likely to experience mental health crises or disorders? So the population I looked at was nursing students, the intervention was nursing school, the comparison was to those not experiencing mental health crises, and the outcome was the increased incidence of mental health crises. So the purpose of my first article was to assess the academic stress and the mental health of nursing students to determine the relationship between those 2 variables. This study results suggested that the mental health of nursing students increases, or when the mental health of these students increases, their academic stress decreases. So that shows an absolute definite correlation between those 2 factors, which is very important for us to look at. And for the second article, its purpose was to examine the mental illnesses of nursing students in Sri Lanka specifically, which these illnesses included depression, stress, and anxiety. And the researchers of this study found that the incidences of anxiety, depression, and stress were all higher in nursing students. They also concluded that early recognition of these poor mental health statuses of these students is imperative for their ongoing psychiatric health. For article number 3, the purpose of it was to identify the risk of suicide in these nursing students, considering their academic environment as well. This study resulted in that 53.3% of the students were at risk of suicide and 20.7% were at high risk. And when you think about it, 21% is not that high, but we're talking about suicide risk in students, and any number of students at risk for suicide is a big deal. So it's absolutely something that we need to consider and we need to fix. And then the purpose of my 4th article was to look at the psychiatric conditions like anxiety, stress, and depression in undergraduate nursing students. The results of this study showed that 37% of the 4th-year nursing students had symptoms of depression, 49% had symptoms of anxiety, and 35% had symptoms of stress, which clearly outlines the prevalence of these disorders in this group of individuals. And my 5th and final article, its purpose was to review the literature regarding the amount of depression, anxiety, and psychological distress in medical students outside of North America. And now I know this sample size it does pertain to medical students, but considering the rigor of their curriculum and ours as nursing students, it's the same or very similar. So we can conclude the same results for us as them. And this study showed that depression and anxiety were increased in medical students compared to students of that same age that weren't medical students. So some common themes that I found while I was researching this literature was that it showed that nursing students do experience severe amounts of stress and other psychiatric disorders, and they are at greater mental health, or they're at a greater risk for mental health crises, which, like we discussed, includes depression, anxiety, stress, and other conditions. So a big common theme that I found throughout all of these articles was that we need to put interventions in place that enhance the mental health of these students. So what kind of interventions could we put in place? They could include having on-campus psychiatric resources for students, even having free mental health screenings or low-cost mental health screenings and treatment for these students. And then lastly, having and encouraging students to express their mental health, and if they need treatment, to express that. Because I know there is a huge stigma around mental health everywhere, but especially in young people. And so we need to kind of get away from that stigma and encourage these students to reach out, because we really do care about the mental health of all the students. And so it's imperative that they reach out and they're comfortable if they need help. So after all of that, how is that relevant to nursing? if you think about it, nursing majors are the next generation of our healthcare professionals. And so it's imperative that we identify these disorders and mental health conditions quickly. And I have the quote here that says, poor mental health status among nursing students has a significant impact on future health and development in the country. And so a small amount of stress, anxiety, and things like that, they can motivate us. Even fear can motivate you, but in a small amount. So it's when we get into those excessive amounts that it becomes a barrier to either concentration, problem solving, decision making, and even other abilities. And all of the abilities that we just listed are essential for nurses to possess, and even nursing students. So they need to be able to adequately learn in their academic environment to ensure that they have the knowledge and the skills that they need to take care of patients after they graduate. So the real question remains, if the responsibility of these students in the future is to protect and save the lives of the public and ensure their well-being, don't we also owe it to them to ensure their needs are also being met? Anybody have any questions? Yes, Dr. Huff. That's a good question. Sometimes I feel like just checking in with students, even like an anonymous survey, like how are you? Do you have any like, I don't want to say complaints, but like things that need to be worked on. And I know even here, y'all have done a great job of just checking in with students, you know, how can we improve and things like that. And I think that's one of the main ways that you can kind of connect with your students, and just to simply ask, and even anonymously, so they feel comfortable reaching out, but just to be able to tell someone. Yes, Dr. David. I didn't find anything specifically, not in the just articles that I read, but I would be interested to look further into it and see if there were specific actions that have been taken place by, you know, specific schools. I think that would be better to, you know, to add to this research for sure. Anyone else? Okay. Thank you.
Does anybody care about the specific time? Does it matter? I'm going to try that.
Okay.
I had to write it down.
Screen share. Do you want me to do this one?
I guess so, yeah. Okay, should be good now. Thank you.
All right, just make sure. Yes.
All right.
Thank you.
Okay, so let's try this again. Now that our files are going to just got us started. So this is Casey Ellis.
Yes.
Okay. All right, good afternoon, everyone. My name is Casey Ellis, and today I'm going to be talking about COVID-19's impact on nurses' mental health. So just a little bit intro and background to get us started. COVID-19 is currently responsible for over 250 million plus global cases, and they're also responsible for over 5.04 million plus global deaths. And the US is actually ranked #1 in the most amount of reported cases and deaths globally. Now, of course, COVID-19 has brought about physical manifestations on the people, ranging from being asymptomatic and contagious to a dry cough, all the way to COVID-induced pneumonia and even death. But for this project, I really wanted to focus my research on the mental impacts the COVID-19 pandemic has had on the people, but specifically what it's had on nurses working throughout the pandemic. So this led me to create my PICO, or evidence-based practice question, that I based all my research on, which is, are nurses who have worked through the COVID-19 pandemic at an increased risk for a decrease in overall mental health in comparison to those nurses working prior to the pandemic? So I did about 6 articles I reviewed for my research. And the first article that I found, researchers' purpose here was really to look at what mental health issues nurses reported developing due to the pandemic. And then also it was looking at what conditions or like contributing factors they felt like were somewhat responsible for them developing these issues. And researchers did this through surveying 5 different hospitals in Portugal with a sample of about 829 nurses. And they found that 40% of the sample reported developing insomnia, 24% reported developing anxiety, and 22% reported developing depression due to the pandemic. And some of the most common contributing factors that they listed was the lack of PPE, the reusing of PPE, the fear to become infected, as well as the fear to infect the others around them. So I actually, for my research, interviewed about 6 different nurses on the pulmonary unit where I'm interning this semester, and I got their answers on some of these questions. So they said that for them, it was the fear to infect others coupled with the lack of PPE on the unit. So the strength of my article here was that the sample was surveyed 3 different times to get an average statistical value. But the weakness here was that 80% of the sample was female. But this is relevant to my PICO because it is showing that nurses were reporting developing these mental health issues due to the pandemic and these specific contributing factors. So article number 2, I'll be kind of repeating myself with these purposes, but they were essentially researching the same thing. They were just trying to see where nurses were at mentally during the pandemic. And they did this through a web-based survey through 9 different hospitals in the United Kingdom, where they amassed about 709 participants in the sample. And they found that 51% of them did report having a good well-being, but although that is so, 45% reported developing depression, 40% reported developing PTSD, 11% reported developing severe anxiety, and 7% of them even reported developing problem drinking due to the stress of the pandemic. So at par, the most common response was that majority of them had developed like situational anxiety from everything going on, but that was coupled with the fear to come into work because they felt like those nurse to patient ratios were not safe. So the strength of this article specifically was that there was a fairly large sample size, but the weakness here was that the sample did include other personnel like doctors, aside from nurses. But this is relevant because, like I said, it's showing that while about half of them were having a good well-being, the other half were struggling with these mental health issues. So article number 3 here, this one, again, was doing about the same thing. It was looking at what mental health issues or illnesses nurses reported developing, and then it explored those conditions or contributing factors again. And they did this through a web-based survey through members of the Provincial Nurses Union, where they had about 48,000 people participate in this study. They found that the highest reports were of high emotional exhaustion amongst the group, followed by reports of depression, and that was followed by reports of anxiety. And some of the most common reported working conditions amongst this group were the shortages of PPE, the insufficient staffing on the unit, as well as the inadequate safety precautions in place. So the strength here was that it did explore the working conditions and some contributing factors responsible and gave a little bit of that background and insight. But the weakness here was that there wasn't necessarily a specific percentage breakdown of who more or less reported emotional exhaustion, but researchers said that was what was most reported. But this is relevant because, like I said, it is still showing that breakdown in how many people had experienced these mental battles. So my 4th article here, this one, researchers' purpose was essentially to look at nurses' feelings towards their current job position during the pandemic. And they did this through surveying various hospitals in New York and Illinois. And they had about 6,500 nurses in the sample here. And they found that 48%, so almost half of them, reported developing high mental burnout from the pandemic. And because of that, 24% of them intended to leave their current job position. And then many requested reduced working hours, which of course we know how that probably would have went. And then some even considered 12% wanted to retire early due to these conditions that they're in. So the strength here was that there was a fairly large sample size, but the weakness here was that it didn't necessarily look at specific mental health illnesses that nurses developed, but it is relevant because it did look at that high prevalence of mental burnout amongst these nurses. So article number 5, this one essentially was doing the same. They were really just trying to look at what mental health issues or illnesses they were reporting. And then it also looked at those contributing factors as well. And they did this through sampling a group of nurses from the Canadian Federation of Nurses Union, where they were all surveyed. And it was reported that majority of them had developed anxiety, and that was followed by reports of them developing depression. And some of the most common contributing factors here was, of course, the issues with PPE, the long working hours, the inadequate staffing, the isolation from family and friends, and managing, like not being able to be at home and managing like family at home responsibilities. The strength here was that they did look at what mental health illnesses nurses reported developing, but the weakness here was that there wasn't necessarily a sample size listed. It was just listed as a large sample, but this is relevant because it's essentially answering my PICO and showing that nurses were in fact reporting developing these mental health issues due to the pandemic. So my 6th and final article, this one again was exploring those mental health issues nurses reported, but also their most common coping mechanisms they turned to. So they did this study through surveying various hospitals in China, and there was roughly 11,000 people in the study. And they found that 81% of them reported developing anxiety. That's just baffling to me. And that 49% of them reported developing depression, and 31% of them reported developing insomnia due to the conditions of the pandemic. They said that 80% of them had utilized support from family, 65% utilized social support of friends, and 13% utilized telehealth therapy or counseling to cope with this. So when I interviewed those nurses at PAR, they had said most commonly that it was the support from family and friends, but coupled with that support within the unit with each other as coworkers, to have someone to lean on, to go to somebody, that was very big for them during that time. The strength here of this article was that, yes, it was looking at those mental health illnesses nurses were reporting developing, but the weakness was that the sample did include doctors as well. And this is, of course, relevant to my PICO because it is showing that nurses were reporting developing mental health issues due to the pandemic. Okay, so the common theme throughout my articles is, I feel like a broken record, COVID-19 pandemic has in fact led to an increase in nurses reporting mental health issues. But the common strengths here is that a lot of times there was large sample sizes in the studies, and that data was a lot of times recorded prior to and considered prior to and during the pandemic to get that statistical analysis. And then the common limitations were that the sample sometimes included other healthcare personnel, or that sometimes specific statistical values were not listed in the results. So in conclusion, overall, more nurses have reported developing mental health issues due to the COVID-19 pandemic. Although this is so, I do feel like research is definitely necessary in the future to study those long-term mental health effects that the pandemic has had on nurses working throughout. And I think that one thing that I suppose we can all take away from this today is that something we can do to help out nurses, something we can do to help out each other during these kinds of times, is to just be there for each other, to be kind, to be patient, to be understanding, to not judge. And then maybe at that point, we can all get through this together with a little less mental stress. Thank you. So it's basically the way that we model our research question. So, oh goodness, the component, yeah, population, interpret, oh gosh. And then outcome, yeah. Right. Yeah.
So in evidence-based practices, we get 2 interventions and we compare the 2 to see what would best benefit the population.
Right.
Just from my own experience at FAR, do you feel like the nurses on pulmonary, do you feel like some of them were considering this leaving, retiring early?
Definitely. And some of them are still, because it's still an uphill battle, you know. They're not the COVID unit anymore, but a lot of them are stressed and burnt out, and the ratios still aren't, I would not say very safe sometimes, which is unfortunate.
In your experience in looking through this research that you've got, I'm just curious if you managed to see any responses that hospital administration or administration is doing to try to help support nurses. Have they come across any action plans or anything? Do you know?
I mean, I haven't heard of any. I just know during the time, as far as the PAR pulmonary unit, the only thing they were about given was what they call the Zen room, which is where they could all go to get some quiet, but you also had to have the time to go to said Zen room. So no one really got to utilize that. So yeah, it is. So compensation is needed. Yeah. Okay, thank you.
We actually had a teacher here in Georgia created a Zoom room. Yeah, lots of teachers zoomed into that thing when they could. It was quite nice to have you.
I'm going to come back over here. Okay, so this is Travis McCart. I'm going to turn the floor over to Travis.
Hello, as you just heard, my name is Travis McCart, and I will be here giving you a talk today on using social skills therapy to possibly improve the negative symptoms of schizophrenics. So schizophrenia is among the top 10 most disabling mental conditions in the world, obviously characterized by distortions in thinking, perception, hallucinations. We've all seen movies and stuff where it's very Hollywooded up and everything. But it can even go into things such as emotional dysregulation, loss of language, loss of sense of self, and affect your entire behavior. It's among the top 10 most disabling mental conditions, as I said, and it is estimated to have impact on possibly 20% of the world's population from people being interacted with and affected and having to treat them. So my PICO question was, in chronic schizophrenia patients, do social skills group training sessions increase social functioning compared to standard care? You can see all the pretty things. Obviously, using chronic schizophrenia patients and hoping that the social skills group will train them compared to standard care, with the hope that they'll have increased social functioning, having greater social interactions with peers. All right, so some of the background on schizophrenia. The symptoms can be divided into positive and negative. Positive symptoms are ones that are present in other illnesses. So that would be kind of like the hallucinations and things like that, things that are very characteristic of it. They're considered added. And then the negative symptoms, those are the ones that show a decrease in normal functions. They're responsible for much of the poor functional outcomes of those afflicted and remain an actually undertreated thing amongst schizophrenics. That's the things you see like anhedonia, inability to feel joy, alogia, inability to talk, things of that nature. All right, current standard of care is focused most heavily on curtailing the positive symptoms, as I said, the hallucinations, all that jazz. That was much better put into the negative. So to improve the quality of life for patients with schizophrenia, we need to evaluate the current and treatments and determine better ways to treat those patients so that we can be spending less time working on them and also have them have more positive results without relapsing or anything, taking a lot of strain off of us. Social skills training is being evaluated for its effect on the social functioning amongst chronic schizophrenia patients' negative symptoms compared against standard care, which is considered as behavioral therapy, vocational support, and family education. Also medications such as antidepressants for some of the negative effects related to just depressed affect, increasing antipsychotics to try to deal with the negative symptoms that go along with that are affected by the positive symptoms. Yeah. Okay. The intended outcome is for the social skills group training to show improved social functioning as evidenced by more significant number of interactions with peers. Providing social skills training for schizophrenics decreases negative symptoms and improves social functioning. I had 5 scholarly reviewed articles in pursuit of my PICO. These articles were peer reviewed using the keywords schizophrenia, treatment, negative, and social. The articles I obtained through the library, Galileo, and that was it. The following review of the literature of each article contains the purpose, sample size and population, results, and relevance of the article to PICO. Okay, so my first study. This was a quasi-experimental design study that was initiated to evaluate the efficacy of social skills training on the functioning and severity of negative symptoms among 40 newly admitted schizophrenic patients, with 20 being male and 20 being female. They used 3 tools to collect the data from the study, and it was a personal and medical data sheet, social functioning questionnaire, and positive and negative symptom scale. The social skills training was conducted over 15 sessions, with 3 sessions per week lasting 60 to 90 minutes. The results were gathered after the 15 sessions and showed a statistically significant increase in social functioning and a decrease in the severity of negative symptoms. The study concluded that a social skill training program had a significant positive effect on social functioning and overall symptoms of schizophrenic patients after receiving a social skill training program, and should be integrated as an intervention in conjunction with pharmacological treatments and current treatments that we have right now. Article number 2 was a double-blind randomized controlled trial aimed to test the efficacy of novel adapted virtual reality intervention games on social skills in 47 individuals with schizophrenia aged 21 to 60. Social attention was indexed by social engagement latency, which refers to eye tracking patterns recorded throughout the game so that they can be analyzed. The study results showed that negative symptoms, especially the loss of speech, the inability to feel pleasure, and the lack of motivation to engage in social interaction, improved significantly post-assessment. Additionally, attention and emotion recognition improved. It shows that many of the negative schizophrenia symptoms can be effectively combated with just a half hour, with just an hour of VR social skills training, as shown by this study, significantly lessening the time that they would spend at therapy and also increasing the effectiveness of the time that they are putting in. My third one was a single-blind randomized control trial, which was shooting to determine the effects that metacognition-oriented social skills training, which will from here on out be called MOST, had on social functioning of 69 adults aged 18 to 65 with schizophrenia spectrum disorders. They were evaluated based on their social and occupational functioning, with the social and occupational functioning assessment scale at baseline, 16 weeks, and again at 6 months. The study was relevant to the PICO as the conclusion showed significant between group differences in favor of MOST at follow-up on socially valuable activities, personal and social relationships, and a downfall of disturbing and aggressive behaviors. Metacognition was only shown to improve with the MOST group, and MOST appears to have short and long-term positive effects on social functioning and symptoms of the social skills training over the standard care for all signs pooled and social measures outcome. Article 4 was a systematic literature search and meta-analysis of social skills training and related interventions for schizophrenia and psychosis. It involves searches on PubMed, PsycInfo, and Embase, as well as the Cochrane Central Register for Controlled Trials. The search identified 27 randomized control trials involving 1,437 participants, involving trials assessing social skills training against active controls, which includes treatment as usual and waiting list control. The systematic literature search and meta-analysis of social skills training concluded that social skills training demonstrated superiority over treatment as usual active controls, and comparators pooled for negative symptoms and over treatment as usual, and competitors pooled for general psychopathology. This is relevant to the PICO question by showing the superiority to combat these issues most effectively. The results from social skills training on schizophrenia patients may be life-changing for them in the long term while also reducing their burden on society. And my final article was an interventional cluster randomized control trial that evaluated if a primary care-based collaborative care model for people with diagnosis of schizophrenia, bipolar, or other psychoses could improve the quality of life for those suffering from schizophrenia more than standard care by studying 204 adults with clinical diagnosis of schizophrenia, bipolar, and other types of psychosis over in England. The quality of life was measured at baseline and 10 months using the Manchester Short Assessment of Quality of Life. The conclusion was that additional implementation and support was likely to be needed to actually implement this model. They did it with the National Institute of Health, what is it? Over in England. Yeah, and they found that it worked very well, but they just didn't have the resources to actually do it and implement it at the time. So they were working to try to get that established because it showed positive results. The effectiveness of such support may be affected by the practitioner and the service user readiness to change. The analysis of the data relating to the intended outcomes of the interventions indicated that the mechanisms proposed in the program theory had operated as expected. So the articles above show that implementing social skills training on patients with schizophrenia is associated with increased social skills, better personal relationships, and more socially valuable activities. It showed that the training was more effective than standard care, reducing inability to speak, inability to feel joy, no interest in social activities. And all the articles indicated that adding social skills training to a patient's regimen is associated with better results, whether used alone or in conjunction with current treatments. So to conclude, schizophrenia remains a massive burden on the patient, their family, and society at large. Further research and implementation of novel treatments for this disorder are going to be required to actually maximize the benefit for them. These studies show that social skills training is more beneficial than standard care in increasing social functioning, and healthcare workers need to continue to utilize the most effective and up-to-date treatments in conjunction with the pharmacology that we have right now. And these improved outcomes for the schizophrenia patients will help prevent negative symptoms of schizophrenia from escalating to more resource and time-intensive challenges. And by treating problems before they spiral out of control, we can deliver better care for patients with less of a time commitment, helping them in the long run. And there's you some reference. Yes.
I'm just curious, that you simply just pass a law, thankfully, finally, that we're going to be able to use mental health, insurance to pay for mental health claims and health insurance. Do you think that's going to make an impact on what you're talking about with the health?
I think it's possible, but it's really more research dollars and everything like that that would need to go into it. Because I mean, it seems like this we have now just currently, but just bear down and keep doing it like that, as opposed to investing the money to try to change that.
One more question.
Yes.
Some of your articles I know were inpatient facilities. Were there some outpatient facilities, like therapy sessions that included the social skills?
Yes. So the virtual reality one was definitely outpatient. Yeah, they only came in for an hour. They had tried to have people play the game for 2 hours and nobody did it because it was not fun, but they showed great results for the hour and nobody was staying there at that facility. They were just going there to test it and try it out.
Thank you, Chad.
I was worried that it wasn't going to come up. You are here. Thank you.
Hello, everybody. I'm Maddie. Today I'm going to be presenting about the effect of massage therapy compared to traditional treatment for cancer patients. So I also use the PICO method to focus and guide my research. So cancer patients were obviously the population that I focused on. The intervention was massage therapy, and it was comparing to traditional or standard treatment. And the outcome was that massage therapy improves side effects and symptoms in cancer patients. Many of the patients diagnosed with cancer undergo treatments that are most of us are familiar with. Some of these traditional treatments, like surgery and radiation, target specific areas of the body. And some of the other forms of treatment, like chemo, immunotherapy, and hormone therapy, are considered invasive and systemic, meaning that they affect the entire body. All of these treatment options are very important and can save a patient's life, but their side effects can be very debilitating and cause chronic symptoms. According to the National Cancer Institute, there were approximately 16.9 million cancer survivors in the United States in 2019. Among the significant population of survivors and those currently battling cancer, there are numerous long-lasting effects. The article, Pain Among Cancer Survivors from Preventing Chronic Disease, states that pain is one of the most common symptoms experienced among cancer patients and can be caused by cancer itself. For example, tumors pressing on bones, nerves, and other organs, surgery, treatment, and treatment side effects, or other procedures and tests. Other long-lasting effects, such as insomnia, depression, fatigue, nausea, and are major issues among cancer patients currently undergoing treatment and those who are in remission. As discussed on the previous slide, cancer-related side effects and symptoms can be physically and mentally debilitating. Traditional drug therapy for cancer patients related to pain and some of the other chronic side effects includes medications like opioids, antidepressants, anticonvulsants, muscle relaxants, topical medications, and many others. Each of these options can provide cancer patients with significant relief. However, they're not without limitations. These traditional treatments can create a huge financial burden and cause other serious side effects, which just adds to the list of these terrible symptoms that cancer patients are already going through and experiencing. So just to reiterate, the goal of my research topic isn't to discourage the use of these traditional treatment methods, but to examine how massage therapy can be implemented into a treatment plan and how these patients can have improvements in their symptoms. So what are the benefits that cancer patients can receive from massage therapy? So it is a safe, well-accepted intervention that can be used as an adjunct to treatment. And based off the information I gathered from the scholarly articles I chose, numerous studies and trials showed significant improvements in patients' perceptions of pain, fatigue, nausea, and anxiety when given 20-minute massages during chemotherapy or their biotherapy infusion treatments. That it also showed major reductions in cancer-related fatigue for patients in a randomized clinical trial who received 45-minute sessions once per week of Swedish massage therapy for a total of 6 weeks, compared to patients in control groups who received either light touch or no massage therapy at all. They also showed immediate reductions in depression and anxiety levels after massage therapy compared to control groups receiving standard medical care only. And it also showed improvements in quality of sleep in a clinical trial with experimental group receiving a combination of medical and massage therapy versus a control group who received medical therapy only. And the group that was being treated with traditional medical therapy showed no significant differences in quality of sleep. So one of the pilot studies from the Clinical Journal of Oncology Nursing evaluated cancer patients' overall satisfaction with therapeutic massage during their chemotherapy or biotherapy treatment sessions and their perceptions of pain, fatigue, nausea, and anxiety before and after massage therapy. While a lot of other variables were assessed during this study, the pain was the main side effect that was reported to be significantly reduced. Many of the participants in this study said that massage therapy specifically helped with their neuropathy pain, stiffness, and swelling. And one of the main limitations with pretty much all of the studies was that looking at certain symptoms of cancer-related side effects, it's all subjective, so it's really hard to evaluate like specific measures because these are subjective. Okay. Another major side effect that cancer patients face is fatigue and insomnia. The Iranian Journal of Nursing and Midwifery Research conducted a randomized control trial with 57 breast cancer patients. The purpose of the study was to determine the effect of massage therapy on quality of sleep by comparing the results between the experimental group who received medical and massage therapy versus the control group who received medical therapy only. Results from the study showed significant improvements in the mean scores of quality of sleep in patients from the experimental group. However, there were no significant differences or improvements in quality of sleep in the control group that were only being treated with medical therapy. Another randomized clinical trial conducted by the International Journal of the American Cancer Society evaluated chronic fatigue in breast cancer survivors with the implementation of Swedish massage therapy compared to light touch and weightless control, which was the group that didn't receive any form of massage therapy. Results from this study showed a reduction in cancer-related fatigue for patients in the Swedish massage therapy and light touch groups, with the Swedish massage therapy having a greater impact. The weightless control group actually reported increases in cancer-related fatigue after the study was completed. So a diagnosis of cancer, as we all know, not only affects a patient's physical health, but it really affects their mental health as well. And mental health, as we have heard in both of these other presentations, is a symptom or an issue that is overlooked often. So it's essential for us to look at other treatment options to enhance quality of life. A literature review from ISR in nursing discussed that there were reductions in patients' perceptions of anxiety, even with short duration of massage, as well as improvements in mood through massage therapy. Once again, I just want to emphasize that obviously we know that massage therapy doesn't cure cancer, or it probably wouldn't just cure anxiety and depression, but it is an alternative form of therapy that may be cheaper, that may be more accessible, that can be added to a patient's treatment plan in hopes to provide somewhat relief. So the official journal of the Multinational Association of Supportive Care in Cancer conducted a randomized control trial to examine the immunological parameters in breast cancer patients receiving massage therapy. The article states that chronic stress is associated with persistently elevated catecholamine and glucocorticoid levels, which both have a suppressive effect on cellular immunity. They also stated that the functionality of the immune system, and especially the Th1-Th2 ratio, is highly relevant for cancer patients. So one of the main parameters focused in this study was that Th1-Th2 ratio. And like I said, it reflects immunity against tumors and infections. There were 17 patients in the experimental group who received 30-minute massage sessions twice per week for 5 weeks, while the 17 participants in the control group received standard care only. Questionnaires and blood samples were taken before, during, and after implementing massage therapy, and some of the results showed a major decrease in depression and anxiety in the massage group. However, there were no significant results for the immunological parameters that they were trying to look at. They had stated that some of the previous studies had found that massage therapy can enhance cellular immunity, but research is still lacking big time on that, the immunotherapy and everything. So further research is definitely needed in determining the benefits of massage therapy at the cellular and immunological level. For my research topic, the evidence provided in all 5 articles involving massage therapy and its effect on cancer patients shares a common theme. This theme is that massage therapy is a very safe intervention that can be used for symptom management. 3 out of the 5 articles were randomized control trials that separated participants into experimental groups or control groups to observe the effect of massage therapy on patient outcomes compared to traditional treatment or medical treatment, or in comparison to no intervention at all. While each of these trials had specific limitations, all of them provided evidence that massage therapy has a beneficial effect on the symptom in question. Another common theme was the use of patient questionnaires to gather baseline data, as well as pre and post intervention with massage therapy. So the 5 articles I used, I gathered through the Google Scholar and EBSCO host through Piedmont University Library. They had to be articles from 2011 to 2022, scholarly and peer reviewed, and included massage therapy for cancer patients regardless of the type of cancer. And I just searched massage therapy, cancer patients, quality of life, and improvements in side effects. So symptom management is of great importance for cancer patients, including those who are currently undergoing chemo or radiation and those who are in remission with long-lasting side effects. Once again, the goal of this literature review is not to discourage the use of traditional treatments, but to examine how patient outcomes can be improved when massage therapy is utilized as an alternative method or adjunct to treatment to a cancer patient's treatment plan. We can apply this information to nursing by identifying and advocating the need for alternative therapies for patients who are not getting physical and emotional relief from traditional treatment methods. Thank you.
So I noticed that like the only type of massage that was ever was Swedish massage. Did they ever do any other types like Thai massage and stuff?
Well, there was a lot of different, like they would ask the patients before they did the massage, like, do you have specific areas? Do you have like a certain pressure or whatever? But that one was the main article that did like a different type of massage. But they varied pretty much in that sense of like the pressure in certain places. So.
Is this a standard practice that's starting to happen?
So I wouldn't say that like I see a whole lot of nurses do massage therapy on patients. I really wanted to just see how, because I've seen patients or I've had loved ones who have had cancer, and it's more like, they go through all these treatments and they have all these other side effects. So they're taking more medication, more side effects. And I wanted to see how, like, as a nurse, how we could advocate for patients to get this different alternative treatment. So that's kind of, I don't necessarily see it, but I think it would be great for nurses to kind of speak up and advocate for that to happen, to be added.
Actually going to be point on nurse-patient ratios and the lack of time for this type of therapy.
Right. I have actually seen a lot of patients in the hospital at PAR when they need like outside resources. The case management usually comes in, but I see a lot of the nurses, they see the patients one-on-one most times. And so they'll call and say, look, I think this is a good idea for this patient. Maybe we can, add that into their plan. So that was kind of my thoughts with it. So. Yeah. Right.
I haven't been through it myself. I can tell you that it wasn't a pain or fatigue or anything, but it's just a mental part of it.
Right.
Really helped, I think.
Right. Thank you.
There are 2 on here for some reason, so I'm gonna go with the most.
They said the same thing because there was 2 things where they submit them.
So let's go with the most recent one, right?
I just wanted to make sure I submitted it to the right place.
Let's see. That looks good. we can.
No, it's okay. Stand up on the
All
stool.
right, we'll let Anna take the stage.
All right. Just tell me when you want me to start. Okay. My name's Anna Oimby, and I'm doing my presentation on the effects in nursing regarding to a low nurse to patient ratio. So a little background. The reason why I chose this topic is because I have been in the hospital as a CNA, and also during my clinical time with Piedmont, I've seen how patient to nurse ratios can really affect like the quality of care that the patients receive, as well as like the quality of care the nurses receive. So the PICO question that I decided on was in ICU patients, how does increased nurse to patient ratio compared to lower nurse to patient ratio affect nursing care within the hospital stay? That's a mouthful. But what is a nurse to patient ratio? This is the number of patients each nurse is responsible for during their shift, and it can vary from each facility. So typically in an ICU, which is what I'll be specifically talking about today, typically they have one nurse per 2 patients. So that can vary based on obviously like the staffing that's available. So the effects of the increased patient load include increased risk for infection, increased patient falls, pressure sores, infection, blood clots, increased length of stay in the hospital, and nurse burnout and work left undone. And I'll also discuss poor work or poor shift handoff and like increased morbidity as well. So the first article that I found is called The Efficacy of Using Available Data to Examine Nurse Staffing Ratios and Quality of Care Metrics. This article demonstrated the effects of nurse to patient ratio and how this can impact the quality of care that the patients receive. The population was nurses and patients in the given hospital's ICU. The variables that this article considered were the patient needs, the intensity of the patient care requirements, and what each patient's particular like workload that they required was, time spent in the execution of operational requirements, and these factors increase the time the nurse will spend in the patient's room. So the initial nurse to patient ratio was 1 to 1.75, and after the change was implemented, the ratio was 1 to 1.5. So the concluding results was there was a decrease in UTIs from 12 to 3. Ventilator risk or ventilator related infections decreased from 4 to 1. Pneumonia infections also decreased from 1 to 0, as well as pressure ulcers decreased from 26 to 22. But the problem that they saw when implementing more nurses per patients was that it's not so easy to just hire more nurses as the ratios increase. So they can't just instantly hire a bunch of nurses to make it easier on each other. So it takes a while to make these changes. The second article was nurse staffing effects on patient outcomes in safety net and non-safety net hospitals. This examined the relationship between nurse-patient ratios in safety net hospitals versus non-safety net hospitals. So I learned what a safety net hospital was, and it's a medical center that provides healthcare to patients no matter their insurance or ability to pay. So this increases the patient census in the hospitals. So they're just taking on all these patients, and they typically don't have all the staff to take care of these patients like they should. So that makes it harder, and they'll have poor outcomes if they don't do something about this. So the population was 872 patient care units from 54 teaching hospitals with a focus on ICU patients. And like I said, this is linking the quality nursing care to the amount of nursing staff that's on the given unit. The concluding results were considering both nurse staffing and the safety net status of the hospital. There was a significant interaction for CHF mortality, failure to rescue, infections due to medical care, and excessive length of stay were seen when there was a increased nurse to patient ratio. increasing nursing staff will decrease the adverse patient outcomes. So a limitation with this article was there was a small sample of ICUs, which kind of limited the results to a small sample. Article 3 was the impact of nurse staffing levels in the nurses' education on patient mortality in medical and surgical wards. This article focused on, like I said, the inadequate nursing and the relationship to adverse events, as well as how the different levels of education that the nurses had can affect the patient outcomes. So population was patients in 14 medical and 14 surgical wards in 7 Belgian hospitals. And although this is not specifically an ICU, it still is relevant because they're facing the same problem that they're facing in every other unit that we see in the hospital is short staff. So this can increase risk on that unit. The research focuses on the variables of age, crude ward mortality, unexpected death with CPR, unplanned interventions in the ICU, and NHPPD. I also learned what NHPPD was through my research. And this is the nursing hours per patient day calculated by dividing the number of nursing hours available by the number of patients admitted to the unit over 24 hours. So basically, in a nutshell, that just means how much time the nurse is spending in that patient's room per shift or per 24 hours. And that can really affect the amount of care. I think like Casey said in her presentation, a nurse may be spending more time in one patient's room and not getting something done in another patient's room. And that can negatively impact the other patient that doesn't require as much care. So by decreasing the amount of time that we have to spend in a patient's room or having more staff to decrease that time can positively impact all the other patients on the unit. So the concluding results was a correlation between units with a higher NHPPD had a lower mean proportion of patients who experienced unexpected death, CPR, and death after CPR. There was limitations, which were absence of patient turnover in the investigation and the lack of EVP research on this topic to back up the findings. Article 4 is registered nurse staffing workload and nursing care left undone and their relationships to patient safety in the hemodialysis unit. And like I said, this is in the past article, even though it's a hemodialysis unit and not specifically ICU, it still relates because of short staff. So this one mainly focused on the workload left undone by the nurses and patient safety outcomes. The study demonstrated poor handoff or shift change report shown by many of the participants, resulting in only 34% reporting a positive and practical experience. And that was coming from the nurses on that shift. The concluding results, after there was a change, for every 1 patient increase in the nurse's assignment, on the last day worked, patient shift change safety scores decreased by 5%. For every 1 unit increase in respondents' workload scores, patient shift change safety scores decreased by 5.4%. For every 1 unit increase in the number of nursing care activities left undone, respondents' ratings of patient shift change safety decreased by 5.4%. And so lower patient loads will decrease the nursing discrepancies and incidences overall. And the limitations were this was limited to nurses who worked in the hemodialysis center, like I said. And the last article was the effect of nurse-to-patient ratios on nurse-sensitive patient outcomes in acute specialist units. This article aimed to determine how caregiver staff levels are associated with patient-sensitive outcomes in the ICU or cardiothoracic units. And the population was very large. There was 175,755 patients from 6 studies admitted to the ICU and cardiac units. 3 studies conducted in ICUs reported an association between an increased nurse to patient ratio or the NHPPD or higher nursing staff levels, resulting in less adverse patient outcomes. And those outcomes, like I said before, are the infections, risk for falls, morbidity, infection, ulcers, And the concluding results from this article was increasing one nurse, patients were 14% less likely to experience in-hospital mortality. And it demonstrated higher nursing staff levels were associated with reduced mortality, medication errors, ulcers, restraints, disease, and pneumonia based on patient admitted to ICU or thoracic units. And this was limited because there was a combined population in acute specialty and non-specialty units. So the synthesis of the literature for this presentation, there was obviously positive results when the ratios were changed and more nurses per patients. So adverse patient outcomes that were decreased due to change were medication errors, pressure ulcers, hospital-acquired infections, blood clots, use of restraints, 4-shift change reports, and undone nursing tasks were just a few examples. Each article supported by PICO and demonstrated the impact of nurse-patient ratio, although some articles were limited to just, or to outside of ICU nursing, the research still supports the question. So in conclusion, the research shows that when nurses are given more patients, there is more risk for error. The positive effects for decreasing the nurse-patient ratio are evident in the research, as well as both patients and nurses were impacted by the ratio change in a positive way. Here are my resources. Yeah.
So I'm just curious how in the healthcare industry, is there a regulatory body that says you can only have 6 patients for every nurse? If you don't have that, you have to bring somebody in.
Yeah.
Is that regulated?
Well, there should be, there's supposed to be, and there's probably one written down somewhere, but they don't always follow that because you can't always, if you don't have the staff, you kind of just have to make do with what you have. So like I know during COVID, it was really bad. And we had our director of nursing working in our units because we were so short staffed that we just kind of had to pull whoever was available. We had to pull labor and delivery nurses to our med surge floors because we didn't have any nurses to take care of the patients that was given. So in an ICU, typically they have 1 nurse per 2 patients. But on a med surge unit, they can have 1 nurse to 7 patients sometimes. Like it can get up to that much because there's so many patients and we're in a shortage of nurses right now. So it's hard to make that change. Like I said, it's not an instant fix because you have to go through all the hiring and people want paid more and all that. So it's kind of a hard situation as management as well. I mean, it's really hard on nurses, but like it is really hard on management that has to make the change or step up. So yeah.
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 Which they say not to in some states.
Yeah. Yeah, because it fluctuates so much too. Like every day you either have a super high census or you have a low census and you send people home. Like it fluctuates so much every day. So I don't know if there's actually like a,
especially the patients that don't have some kind of advocate.
Yeah.
They're all by themselves.
Yeah.
They don't have family members to say, hey, my dad hasn't had his medication.
No, I agree.
You know how it is in our field, in education. You just put many people. That's exactly right.
Well, the problem that I've seen specifically, like as I've done my clinical in the ICU at Piedmont, is if there's like a code going on where a person is in cardiac arrest, they have to have so many people going in there. So at Piedmont's ICU, they have 4 sections based on what your condition is or what, like if it's surgical or if it's medical and all that stuff. So if there's a code in medical, some nurses from surgical have to leave to go help. Well, then you're kind of short in the unit that they all left from. So you kind of have to, I don't know, it gets really tricky. You almost need like backup nurses, and then you have to think about travel nurses and yeah. Yeah, they have float nurses at most hospitals that float to different units as needed. But that's not always like supple either. So it gets really tricky whenever. Yeah. Mhm. Yeah. Don't come, yeah.
Well, in Rockville County, did you hear in the news in Rockville County, they wheeled that man, still has tubes in his body. They put him in a wheelchair and wheeled him to the end of the
Yeah, my wife and I witnessed that.
Did you see that?
We lived out
But
there.
didn't have, I don't know what the issue was, if his insurance ran out.
His Medicare ran out. And they were under federal investigation now. That's not the
Yeah.
first time that's happened.
I cannot imagine on your level as people working on the front lines. That's gone. So frustrating.
Work at the health department. Thank you.
I'm just going to stop the recording. So, thank you, judges.
I know, it seems like they just started.